Now, ma'am. Good evening, respected faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by AMOGS Medical Disorders Committee with SP Palghar, Gadhinglaj, Ratnagiri and Sindhudurg OBGYN societies. So it's my privilege to welcome the MOC of today's webinar, Dr. Madan Kambal sir. Sir is a consultant obsgyn and aesthetic gynecologist. Sir has been the chairperson of AMOGS Aesthetic and Sexual Medicine Committee from 2022 to 24. Sir has been the past secretary and president of Akluj OPGYN Society and also the member of Foxy Sexual Committee and Council of Sex Education and Parenthood International.
It's okay, ma'am. It's okay.
Yeah, I welcome you, sir, and I hand the session to you.
Yeah, thank you, Ms. Sahiti. Yeah, myself, Dr. Madan Kamble, one of the coordinators of this prestigious webinar started by respected Dr. Sneha Buyar ma'am through AMOGS. This webinar has been arranged by AMOGS Medical Disorders Committee along with our Maharashtra societies of Palghar, Gadhinglaj, Ratnagiri and Sindhudurg. It's my privilege to welcome the AMOGS office bearers, respected Dr. Pardeshi sir, President AMOGS, Dr. Sujata Dalvi ma'am, Dr. Kiran Kurtkoti sir, and today's chief guest Dr. Asha Dalal ma'am, guest of honor Dr. Kalyan Barmade sir, and today's speakers, all the panelists, and I welcome all the chairpersons of all the sessions of this webinar and presidents, secretaries of all the associated 4 societies and all the delegates who have joined from all over Maharashtra for today's webinar. I welcome from the bottom of my heart, and I welcome Dr. Sneha Boyar ma'am for this for further, and I request all the dignitaries to join the virtual lamp lighting. Thank you, all the dignitaries, for joining this inaugural lamp lighting. Now I welcome Dr. Sneha Bhoyar madam. I would like to introduce ma'am. Ma'am is currently the AMOGS chairperson for Medical Disorders Committee. She was Foxy chairperson for Breast Committee in 2019 and 21. And she is governing council member of ICOG. She has in her name so many awards and publications. I welcome ma'am to give your address.
Thank you so much, Madan, for that kind introduction. A very good evening and warm welcome to all the respected seniors and dear friends here. My special gratitude to today's dignitaries, especially Madam Asha Dalal, the chief guest for today's program, Dr. Kalyan Baramde as guest of honor, respected President AMOGS, Dr. Pardeshi sir, and Madam Sujata Dalvi, the secretary of AMOGS. I also welcome Madam Nandita Palshitkar, the immediate past president, and Dr. Kiran Kurtkoti as president-elect of AMOGS. Our today's seasoned orator for today's program, Dr. Bela Bhatt, who is the Foxy chairperson for Imaging Science Committee, and also the medical legal expert from Palghar, who is the secretary of Palghar Society, Dr. Rajendra Tiwari. I welcome all the president and secretaries, especially Dr. Rajendra Chavan from Palghar, who is the president at present, Dr. Kiran Hatti, the president of Gadhinglaj, Dr. Ranjit Patil, the secretary of Gadhinglaj, Dr. Sanjay Nigudkar, president, and Dr. Shamita as secretary, all the esteemed faculties, panelists, and chairperson for today's program. Being a hardcore obstetrician, I have always experienced that, yes, though obstetrics is uneventful, definitely we do have some predictive factors, and we can definitely take some preventive measures as well. And that's the very reason whatever panel discussion we are including in our program. that includes the management of the acute catastrophe as well as the preventive measures. So with this, I welcome all of you once again. I take the blessings of all the respected seniors, and definitely I would like to thank all the societies for their active participation. And indeed, it's a pride and privilege for me to introduce Madam Asha Dalal and have her blessings. So, Madam is such a well-known figure in AMOGS, such a illustrious personality with a highly decorated CV. And Madam is the past president of AMOGS, is the director Department of Obstetrics and Gynecology, Sir H.N. Reliance Foundation Hospital and Research Center. And of course, you have the whole list of accolades to her credit. But what I would like to say about Madam is such a appreciative and encouraging personality. You always feel blissful talking to you, Madam. So we would like to hear from you and definitely seek your blessings. Over to you, Madam.
Very good evening to everybody, all my dear colleagues and friends. Sneha, your society has always got such wonderful programs. And what I would like to say, your topics for today are so topical and so necessary. Many of us do not even think about medical disorders when we are considering a pregnancy, but all of us know that the incidence of so many problems is rising, and all of it is not in our hands. Though we always work as a team, whether it is with a hepatologist, a virologist, a surgeon, a physician, ultrasound is the basic investigation which helps us to a large extent, especially in pregnancies where I wouldn't say that no others are possible, but we take the other investigations only if necessary. And I agree with Dr. Pardesi totally. There is strength in numbers. Medico-legal aspects of everything, all of us should be aware of. We should know not only about what is allowed, what is not allowed, what is the problem, but whom to go to if you do have any of these issues. So I wish all of you all the very best, and I know we are going to have a wonderful 2 hours. Thank you, Sneha. Thank you, everybody.
Thank you so much, Madam, for your blessings. Thank you so much. And Saiti, can we have Dr. Kalyan Baramde's CV? So I welcome you, Dr. Kalyan Baramde, a young upcoming leader from AMOGS, my younger brother. And of course, we are really proud of you. Kalyan was the chairperson for Public Awareness Committee, FOXY, with me, and he's at present he's the secretary of IAG, and soon we wish to see you as president of IAG. Definitely, it's always a pleasure, Kalyan, and we would like to listen to your words of wisdom. Over to you, Dr. Kalyan.
Thank you, ma'am. Respected Asha Dalal, ma'am, respected Sneha, ma'am, and all the people who have taken a lot of efforts for organizing this webinar. Good evening to everybody. I'm so glad to see Dr. Sneha Madam as chairperson of Medical Disorder Committee, who is doing such a wonderful job. Since she was in Breast Committee, FOXY, she has done a wonderful job for 3 years. Now Medical Disorder Committee, she has taken to a definitive big height. Congratulations for that. And for all delegates of Palghar, Gadhinglaj, Ratnagiri and Sindhudurg Society, it's going to be feast because you are going to listen to ultrasound, then medical legal aspect, and the most important part, which is near miss cases. That is very important in our practice, that we should not leave any life, because whatever today we are doing as a gynecologist is for the betterment of the women. And Maharashtra has achieved the maternal mortality, which has come down to 70. We want it to below 30. And such webinars are going to be really helpful to manage the near miss cases, where being only vigilant is important. You have to be very vigilant, and you have to be actively there in the labor room wherever such high risk cases are getting operated or delivered. So I congratulate whole team, and specifically Dr. Sneha Buyar ma'am for organizing such a wonderful webinar on medical disorders. And I wish all the best for her Vice President election. Thank you so much, ma'am.
Thank you so much, Kalyan, for all your precious words, I would say. And yes, it's indeed a pride, pleasure, and privilege to introduce my mentor, Dr. Rajendra Singh Pardesi. He has actually handhold us right from before going to Foxy as chairperson also. All of you know, sir, is the president of AMOGS, and he was the vice president of Foxy, and of course, award-winning chairperson of Food, Drug, and Medical Surgical Equipment Committee of Foxy. Definitely, we would like to see you as president of Foxy, sir, and we would like to listen to your precious words. Over to you, sir.
Yes. Thank you, Dr. Sneha, for kind introduction. Respected Dr. Asha Dalal, our chief guest and mentor of AMOGS. Respected Dr. Kalyan Baramde, guest of honor, Dr. Sujata Dalve, Dr. Kiran Kurthakoti, and our ever active chairpersons, Dr. Sneha Boyar, Dr. Bela Bhatt, Dr. Madan Kamble, Dr. Monica Ubbardan. First, I wish to congratulate Dr. Sneha Boyar and Palghar, Gadhinglaj, Ratnagiri, and Sindhudurg Society for organizing this webinar on medical disorders. And with the eminent speakers like Dr. Bela Bhatt, Dr. Rajendra Tiwari, Dr. Sneha Boyar, Dr. Varsha Lahade, and Chairperson Dr. Rajendra Chavan, Dr. Nigudkar, Dr. Kanchan Madar, Dr. Nilofar, Dr. Rahul, Dr. Supriya, Dr. Nita, Dr. Ashwini. I think this is going to be a great event. I wish every success to Dr. Varsha Lahade for her future endeavor in Foxy as chairperson. And I wish every success to Dr. Sneha Boyar, a right person for the right post of Vice President of Foxy election in future. Wishing every success to this webinar. Thank you. Thank you so much for inviting me.
Thank you so much. Madam Sujata Dalvi is not able to join because of some emergency. So once again, I thank all the president and secretaries of the various societies. I already included the names of Dr. Rajendra Chavan and Dr. Rajendra Tiwari from Palghar, Dr. Sanjay Nigudkar, and also Dr. Shamita from Sindhudurg, and Dr. Kiran Hatti and Dr. Randeep Patil from Gadhinglaj. I thank you, Sir Rajendra Singh Pardesi, for always being so supportive and encouraging to all of us. And with this, I declare that the inauguration has been done, and I hand over the academic session to Dr. Madan Kamble. Thank you so much.
Yes. Thank you, madam. I welcome Dr. Monica Ubbardan, who is my co-coordinator and who is the chairperson of Public Awareness Committee, AMOGS.
I just
would like
need
to
one
introduce-
moment, Dr. Madan. I have
Yes.
already said thanks to everybody, but I give special thanks to both of you, Dr. Madan and Dr. Monica, who has been so much helping to me, and in not only in planning but also the coordinating this event. So a special thanks to both of you. Thank you so much.
It's our pleasure, ma'am. Yeah, I would like to introduce Dr. Monica, who is consultant OBGYN at Mangalya Nursing Home, Solapur. She is currently the AMOGS chairperson for Public Awareness Committee, and she was website coordinator in AMOGS, youth coordinator in AMOGS. She has played very much important roles in AMOGS and Solapur OBGYN. I welcome Dr. Monica. Hand over to you.
Thank you, Madan sir, for the kind words of introduction. I now declare that the inauguration is over, and I would like to take the privilege in introducing the chairpersons for today's session. That is Dr. Rajendra Chavan sir. He is currently the president of the Palghar Society and the past secretary of IMA Boisar branch, the president of the Rural Medical Association, Thane district, the member committee of Medical Practitioners Association. He is also a member of the Association of Medical Consultants, Mumbai, and an honorary surgeon, laparoscopic surgeon to the Zilla of Thane. I welcome you, sir, as a chairperson. I also welcome our next chairperson for today's session, Dr. Kiran Hatti, sir. He is the president of the Gadhinglaj Obstetrics and Gynecological Society. We welcome both of you. Share this.
Yes. Thank you, Monica, madam. Should I introduce Dr. Bella Bhatt? It is always a great privilege to introduce Dr. Bella and to listen to her. She's always, whenever she speaks about ultrasound, I always am entangled in her talk. So, Dr. Bella Bhatt, she is a chairperson of Foxy Imaging Science Committee in 21 to 25. She is a leading consultant in Bella Women's Hospital and Fetal Medicine Center, Andheri. She is fetal medicine consultant in Babasaheb Ambedkar Memorial Hospital, Mumbai, and she is FMF certified sonologist for fetal abnormality, fetal sonology for nuclear scan. She is a life member of Society of Fetal Medicine, Joint Secretary of AFG, and she is managing council member of.
Sir, I think that's enough, sir. I think let's go to the.
And so many things are there. So I think you are welcome, madam. We are eager to listen to you.
Thank you so much, Dr. Rajendra Chavan, for those kind words of introduction coming from a senior like you.
Thank you, madam.
You have been doing excellent work as far as the blood donation and so much in the periphery. We all know you. We can count on you for whenever we need blood for any patient, needy patient. So thank you so much, sir. These words coming from you mean a lot to me. I'm extremely thankful to Dr. Sneha Buyar, a very dear friend, and we know her as a brilliant academician and a very hardworking Foxian and chairperson. For giving me this opportunity to be part of this wonderful AMOGS webinar. And of course, thank you so much, the president of AMOGS, Dr. Pardesi sir. I still remember I started my campaigning for this chairperson with Dr. Pardesi sir's help with the Aurangabad Society. And so thank you so much, sir, for always supporting and encouraging people like us, and all the office bearers of AMOGS for giving me this opportunity to be here. And I see so many friends here. Dr. Varsha Lahade, we were there yesterday also in a webinar. Dr. Kalyani is there, and so many of familiar faces and friends. So it's a pleasure and honor to be part of this webinar. So can I share my screen and start the talk? Okay. So just take it down. Is this thing seen? This is yesterday also. There was some problem with this. I'll resume share. Okay. Can you see it now? My screen is seen now?
Yes, very well.
Yes. Okay. With MacBook, you have some technical issues. Okay. So, fine. I'll straight away start with my talk. So, first of all, Dr. Sneha Buyar has given me this very, very interesting talk on role of ultrasound in medical disorders of pregnancy. Now, we all know that ultrasound today has a very pivotal role in management of pregnancy and to prevent so many medical complications, manage them well, and improve the perinatal outcome. Now, there are many, many medical disorders of pregnancy, but we know the major killers are the preeclampsia and gestational diabetes mellitus, and of course, many more, but I have taken 3 today because considering the time constraint of 15 to 20 minutes, I have taken these 3, the role of ultrasound in preeclampsia, gestational diabetes mellitus, and one interesting case of hyperthyroidism. So, we all know that preeclampsia complicates 2 to 8% of pregnancies and is a leading cause of maternal and fetal morbidity and mortality worldwide. So, let's see what is the role of ultrasound in management of preeclampsia. So we all know now that as far as preeclampsia is considered, we all have turned the pyramid of antenatal care. We don't want to see all the complicated cases of severe eclampsia and preeclampsia in the second half of pregnancy, but we all want to predict that at right 3 months or 11 to 13 weeks of pregnancy and try and prevent that. And that's possible with our ultrasound. So there are some biophysical markers and there are some biochemical markers. So which are the biophysical markers? The maternal and demographic factors, the mean arterial pressure, and uterine artery PI. Of course, I can't go into the details of all, but I'll concentrate on my ultrasound part. So as far as the uterine artery is concerned, we know there are two phases of trophoblastic invasion. The first one, wherein there is residual segment, the trophoblast invade into the spiral arteries between 8 to 10 weeks. But the second one, which occurs at the 16 to 18 weeks in the myometrial segment of spiral arteries, very, very crucial. And that converts the high resistant uterine artery into a low resistance system. And that's how the flow to the uterus increases, which is useful for the growth of the fetus, right? That's a remodeling. And this is how, as the trimester increases, the trophoblastic invasion increases, the blood flow to the uterine arteries and spiral artery increases, and the fetus can grow well. But what happens that when this doesn't happen, then we have complications like preeclampsia and fetal growth restriction. And here our ultrasound comes to help us. So what do? At a nuchal scan, at 11 to 13 week scan, we look at the uterine artery in the sagittal section. Just at the end of it takes just a minute more to do the uterine artery scanning, and you can see, you can move the transducer on either side in the sagittal section, and you will find it in the paracervical or near the internal os. And there we try and take the mean uterine artery PI. We take the uterine artery PI on both the sides, and we take, when the mean of uterine artery PI is more than 95th centile, it puts the patient at higher risk for preeclampsia, fetal growth restriction, and many more. Placental insufficiency, basically, which is what we come to know through this. So normally, if you look at the uterine artery PI, in first trimester, you'll find that the diastolic flow is less, the uterine artery PI is higher. But in second trimester, 18 to 22 weeks, the diastolic flow increases because of lower resistance, and therefore the PI also drops. In third trimester, it further improves the diastolic flow, and therefore the PI drops further. This is what should normally happen in a normal pregnancy. But when this doesn't happen, this kind of a picture when you find in the 11 to 13 week scan, where there is very high PI, very low diastolic flow, and when the mean of the both uterine artery PI is also high, then more than 95th centile, then we know this patient is at risk. Now, we always combine this with biochemical markers. So ideal is to use both PAPA and PLGF, because we know PLGF is a marker for preeclampsia, but maybe at many places PLGF is not available. So at least PAPA is available because we do nuchal scan with double marker, and PAPA is a part of it. So when we combine both, the sensitivity of to be able to predict the preeclampsia is to the tune of 80 to 85%. Now, what is the meaning of screening or predicting high-risk cases of early preeclampsia? Once we have found out that this patient is at high risk by combining these biochemical and biophysical markers, and we know that the risk is more than 1 in 100, then we should have some measure to try and prevent it. Otherwise, there is no point in just telling patient that you are at high risk, right? It's a other side of the coin to be able to prevent this complication. So what do we have to prevent it? Well, we know that before 16 weeks, that is at 11 to 13 weeks itself, if we start some preventive therapy before the second phase of trophoblastic invasion, we'll be able to prevent this complication to a great extent. And the biggest multi-centric trial, which was done by Nicolets et al., FMF UK, is the ASPRE trial. And it is proved beyond doubt that when we use this combination of biophysical and biochemical markers, when the risk is more than 1 in 100, we are supposed to start the low dose aspirin, the dose of 150 milligram, and that prevents a severe form of early preeclampsia to the tune of 90%, and early preeclampsia before 34 weeks to the tune of 82%, which is very good. We know 70% of our population in India is in rural area. So with the help of these 3 biophysical markers, if we can even pick up 75% of cases and apply this low-dose aspirin, will be able to prevent these severe forms of preeclampsia. And I think there the role of ultrasound is extremely, extremely important in the form of uterine artery PI. Well, there are some other markers like reduced index of placental vascularization, 3D Doppler at 11 to 13 weeks, 6 days gestation, but these are all under study right now. There is ophthalmic artery Doppler, which is another newer marker, in which we try and find out the ratio of second peak systolic velocity to first peak systolic velocity. And if it is more than 0.99, again, it puts the patient at high risk of term preeclampsia. But again, we need more Indian studies on this for the values, and then we'll be able to use it in more patients, right? So these are some of the newer markers. I'm concentrating only on the ultrasound, not going into much of the details because of the time constraint. So that was about prediction and prevention of preeclampsia, where ultrasound plays a very, very important role. Now, what is the role of ultrasound in gestational diabetes mellitus? We all know that India is becoming diabetes capital, sadly, because of our sedentary lifestyles, the teenagers who are into the junk food and no exercise and sedentary activities. So even in pregnancy, we see that 15 to 20% patients develop gestational diabetes mellitus. So here, how is our ultrasound going to help us? There are so many challenges in gestational diabetes mellitus, out of which two very important are how to monitor to reduce the fetal growth disorders and how to reduce the chances of stillbirth. So what are the aims of ultrasound in gestational diabetes mellitus? Early detection of fetal congenital anomalies, early pickup of fetal growth disorders, ultrasound in guidance of maternal glycemic control and therapeutic management, which is a recent new concept and is very, very useful. Prevention of stillbirth and timing of delivery. Let's see each one of them. So congenital anomalies, we know as the HbA1c increases in the first trimester or in periconceptual time, the chances of risk of anomaly is very, very high. When it is between 5.6 to 9.5, the risk of anomalies is to the tune of 4 to 5%. And when it is more than 9.5%, the risk of anomalies is 22%. So this is uncontrolled periconception diabetes we're talking about. So how is our ultrasound going to help us? Previously, we used to wait for 18 to 22 week scan. Now at a nuchal scan itself, a very important arm is try and pick up the 50 to 60% of major anomalies, right? And then remaining we can pick up at 18 to 20 weeks. So, and there are many, many, many cardiovascular malformations which are also common in diabetes. So we know that now, even at the 11 to 13 week scan, we can pick up cardiac anomalies, major cardiac anomalies here. You can see this video is not playing well here, but you can see very well that the inflows, the crossover of major vessels and outflows all can be seen at 11 to 13 weeks, and major cardiac anomalies we can even rule out at our nuchal scan. Not only that, there are some markers of congenital heart disease like increased nuchal translucency, tricuspid valve regurgitation, and absent or reversal of A wave in ductus venosus. When this is there, there's threefold increase in CHD. So when we look at these markers as aneuploidy markers, they also give us information. There are chances of cardiac anomaly. Look at the heart closely and we can pick up so many of cardiac anomalies. There are many CNS anomalies we know that can occur in diabetes mellitus, and there are surrogate markers of open spina bifida even at 11 to 13 week scan, like brainstem to brainstem occipital ratio, which can tell us that if this ratio is increased more than 1, we have to look at the spine carefully to try and find out some of the open spina bifida or crash sign on the axial scan, as we can see in the video clip, which will tell us that there is some open spina bifida, and we go ahead and look at the spine, whether there is any spina bifida. There are also chances of acrania, holoprosencephaly, and many, many more CNS anomalies in gestational diabetes, which we can pick up in the first trimester and remaining can be picked up at the 18 to 20 week scan, which can be meningocele, encephalocele. Then there are some other system anomalies like omphalocele, just the diaphragmatic hernia. As you can see in this, the stomach has entered through the defect into the thorax, and the heart is pushed to the right by the stomach and the bowel lobes. The lower urinary tract obstruction, keyhole, bladder. So many anomalies the ultrasound will help us pick up. And I would like to emphasize here that 50 to 60% of these can be picked up at 11 to 13 week scan. We should not wait for this anomaly of pick up at 18 to 22 weeks, right? And can we prevent this anomaly? Yes, we all know by a very good periconceptual sugar control, pre-pregnancy and in the first trimester, we can prevent many of this. That was about congenital anomaly. Now, what is the role of ultrasound in growth disorders? We know chances of large for gestational age is very, very high in gestational diabetes. So can we predict this through the growth charts? So we must know in every pregnancy, we must know how to read the growth chart, and we know when it is between 10 to 90th centile, the growth is normal, less than 10 is fetal growth restriction along with many other Doppler parameters. And when it is more than 90th centile, then it is large for gestational age. Now, what about the role of ultrasound when you did not pick up the gestational diabetes in the first half of pregnancy? You did your PG2BS, it was normal. But between 29 to 33 weeks, if the birth weight is more than 90th centile or the abdominal circumference is more than 75th centile, then it reminds you to do OGTT, that is 75 gram glucose test. Because even if the first trimester OGTT was normal, repeat it and you'll be able to somehow pick up some of the gestational diabetes mellitus, which were not picked up then, but you'll be able to pick up now, because it is the human placental lactogen, which is at its peak at around 28 weeks, 25th to 27 weeks. And that's the reason you'll be able to pick up some of the gestational diabetes, which develop later on. And not only this, even the polyhydramnios, which looks idiopathic without any other congenital anomaly, there is no reason found for that. It gives us a red signal. Look at the sugars again. Do a 75 gram glucose talent test, and 11.8% pregnancies where there is isolated polyhydramnios in third trimester and where the previous sugar was normal, the GDM is picked up. So these are the markers on ultrasound which will help us pick up the gestational diabetes. Now, is there any role of color Doppler in gestational diabetes? Well, when we know where the ultrasound is useful, we should also know where the ultrasound is not useful. Color Doppler does not give you any information about hyperglycemia, and therefore, please do not get misled by apparently normal fetal Doppler status in gestational diabetes in particular. If it is associated with fetal growth restriction in a small segment, yes, you will find changes, but isolated gestational diabetes mellitus, the color Doppler will be absolutely normal because it is not affected by the sugars. Now, again, a very, very important role of ultrasound in guidance of maternal glycemic control and therapeutic management. This is about the mother and its glycemic control. Now, this slide is extremely, extremely important because it tells us that suppose there are two important aims: stricter glycemic control in mothers whose fetus show macrosemia, and relaxing glycemic targets in women whose fetuses are at low risk for large for gestation age. So what do I mean by this? Supposing your mother, you are checking the sugars in your GDM and you find that the sugars are good, the sugar is around 90-95 fasting and around 120-125 postprandial. But when I'm doing ultrasound, the EFW is more than 90 centile, or the abdominal circumference is crossing 75th centile, I know that this glycemic control is not good. I have to be stricter. So instead of 90, I should aim at 85 fasting. Instead of 120, I should aim at 115 postprandial in this particular patient, because on ultrasound, there are signs which are telling me that this glycemic control is not good. Why is the baby developing macrosomia? So be stricter. As opposed to this, even if my sugars are around 130 postprandial and around 100 fasting, but on ultrasound, the baby, the abdominal circumference is around 50, 60 centile. The fetal growth is around 70, 80 centile. It is not crossing 90 centile. I can be little relaxed in this, because if you try to do a stricter glycemic control in this, there'll be fetal growth restriction, right? So either ways, ultrasound actually guides how to maintain the blood sugars in this gestational diabetes. So this is a newer concept, and that really helps diabetologists. Also, they always ask for an ultrasound report with centiles of abdominal circumference and EFW to try and control sugars in mothers. Can we predict stillbirth in gestational diabetes mellitus? Well, we all are scared of sudden SBs in the third trimester in GDM because of the sudden fluctuation in sugar. So not always can we predict, because Dopplers do not help us, as it helps in fetal growth restriction. And short episodes of hyperglycemia are difficult to predict. But we have some hope, because as I said, with ultrasound monitoring and modulating maternal therapy, having a smooth control of sugar will always help reduce these numbers of stillbirths. It should neither be too hypoglycemic nor too hyperglycemic, but a smooth control. And fetal growth restriction related stillbirths also can be preventable with the help of ultrasound. Poorly controlled diabetes, if you terminate at 37 to 38 weeks, again, you'll be able to prevent these stillbirths. So yes, there is a pivotal role of ultrasound in this too. And last but not the least, does ultrasound help in decision making in timing of delivery in this hyperglycemic pregnancy? Yes. If it is a well-controlled gestational diabetes without associated microsomia on ultrasound or any other complications, you can continue till 40 weeks or well controlled on diet and exercise alone. But even if it is well controlled or it is uncontrolled and there is macrosomia on ultrasound or fetal growth restriction on ultrasound, or of course preeclampsia or control with insulin, then we need to terminate this pregnancy at 37 or 38 weeks, because there are very high chances of stillbirth and should not wait till 40 weeks. So again, there is an important role of ultrasound in this. So I think we are clear as to what is the role of ultrasound in gestational diabetes mellitus in nutshell. Now here in hyperthyroidism, we all know it's not very common like hypothyroidism, but I'm going to just share quickly one very interesting case which will tell us how important ultrasound is in hyperthyroidism. It is a thyroid disease is second most common endocrine disorders in pregnancy. Of course, it is hypothyroidism which is more common, but I'm going to take you through a case of hyperthyroidism. So this 26 years old, this is my railway hospital a patient where it was referred to a Central Railway Hospital, Mumbai. So 26 years old with non-consanguineous marriage, second gravida, first para, with first delivery where there was stillbirth female in village, cause not known, papers not available, which is a common scenario many a times, was referred at 26 weeks to railway hospital with blood group O positive, and these were the ultrasound findings. This was on the railway hospital ultrasound machine. So what I found was ascites was there, pleural effusion was there, blood group was positive, the ICT was negative. So this was a non-immune hydrops fetalis at 26 weeks of pregnancy, right? I'm showing you the ultrasound picture first. We try and rule out the cardiac anomalies, the 4-chamber view, the 3-vessel trachea view, everything was normal. There was gross ascites and non-immune hydrops fetalis. But look at this. When you look at the heart rate, it's very obvious that the heart is beating very fast with the heart rate of 220 persistently for half an hour of examination, which tells me that there is something wrong with the heart rhythm and there is non-immune hydrops fetalis. So we must dig into history and investigation and try and find out what is the reason for the same. So I know that this is a heart rate of 232 with 1:1 AV conduction with no other structural cardiac anomaly, no other structural anomaly in the fetus. This is a supraventricular tachycardia. So what is the reason for that? So I digged into the history. got all the reports. Now this patient was from Jabalpur, and the obstetrician did her TSH in the first trimester at 14 weeks, which was 0.01. So it was repeated. The entire thyroid function test was repeated. The T3 and T4 were normal, but TSH was found to be very, very low. So patient was referred to physician who started with the carbimazole antithyroid treatment, 5 milligram OD. And then after 6 weeks at 20 weeks, the TSH was normal. The physician was happy. The obstetrician was happy. But then let's see what happened. At 26 weeks, they found that there is hydrops vitalis. And so the patient was referred from Jabalpur to Mumbai Railway Hospital, Central Hospital, where I scanned. And then the thyroid function tests were repeated in NABL accredited lab in Mumbai. And we found that T3, T4 were both high, and the TSH had again gone down to 0.01. It had fallen. And so we now know that it's a hyperthyroidism which has given rise to the supraventricular tachycardia, leading to non-immune hydrops fetalis. So the patient was referred to physician as well as pediatric cardiologist for anti-arrhythmic treatment. Patient was counseled that this is a kind of cause for NIHF which is treatable, but for that we need to give anti-arrhythmic treatment to the mother. Patient was admitted in the ICU of a railway hospital. Flecainide was started in ICU by pediatric cardiologist of railway hospital. And look at the result. In 5 days, the fetal heart rate came down from 232 to 160. But this patient was coming from periphery, didn't want to stay back here, and patient took Dama, went to village again under physician's treatment and continued with carbimazole. The story doesn't end here. It continues. I took the follow-up from the patient. At 34 weeks, the TSH, T3, T4, everything was normal. And look at the dramatic change in the ultrasound picture. The ascites had gone. The non-immune hydrops fetalis had completely gone. The growth was normal at 34 weeks. And the heart rate again had fallen to 150 beats per minute. Absolutely normal ultrasound report. Again at 35 weeks, 4 days, there is no ascites, no hydrops, fetal heart rate 140 on antithyroid treatment. At 35 weeks, 4 days, the obstetrician had admitted, the steroids were given. We always think that with so much of complications to the baby, the mother should have some symptom of hyperthyroidism. But surprisingly, only the pulse of mother was 106. Rest all patients did not have any sign or symptoms of hyperthyroidism, nor any investigation was abnormal. All the reports of mother were normal. The mother was on neomerkezole 5 milligram OD, that's it. And the thyroid function tests were normal. At 36 weeks, the obstetrician gave a short trial followed by LSCS. A female of 2.4 kg delivered. On day 3, the T3, T4, TSH were normal, as you can see here in the discharge card, with the normal heart rate of the baby. The baby is now 1 year old and is doing well, right? So here we could see that with the help of ultrasound, we could pick up, monitor, and manage this case. Now we know that overt hypothyroidism is very, very uncommon, 0.1 to 1.4% only. And what happened in this case? The TSH was low initially, but the T3, T4 were not high at 14 weeks. Still high drops occurred at 26 weeks. Maternal symptoms not pronounced of hyperthyroidism, still high drops occurred. Diagnosis of hyperthyroidism related complication was possible in this particular case because of ultrasound, in which we picked up the NIHF with the supraventricular tachycardia. So the message here is TSH is gold standard. We must do it in the first trimester. If it is low, repeat thyroid function test in NABL and ISO accredited lab. We know in various labs we get various results. So we must stick to the standard labs. And if it is low, better to refer to a physician or endocrinologist who will then further treat the patient. And what is the role of ultrasound? The ultrasound surveillance in such hyperthyroid patient to look if the heart rate is crossing 180, if the fetus is developing goiter, whether there is vascularization of the thyroid because there is central vascularization in hyperthyroidism, whether the baby is developing any sign of hydrops and cardiac failure like tricuspid regurgitation or DV abnormality. right? So again, the ultrasound is going to help us a lot in USG surveillance in such cases. So this particular case, what if somebody had just seen the heart rate of 230 and non-immune hydrocephalus and terminated? Well, dig into the cause, look at the cause, treat the treatable. Here the cause was treatable and was completely treated. The baby is doing well, is 1 year old now. So we should always try and treat the treatable, and the outcome was very good in this particular case. So as far as role of ultrasound in medical disorders is concerned, we have seen that in preeclampsia, which is a major killer in India today also, we can predict and very well at 3 months and prevent many severe form of preeclampsia. In GDM, again, which is a major killer, we can both help in the maternal glycemic control and preventing many fetal complications. And in hyperthyroidism, we saw that it can prevent and manage fetal complication very well. So I think in nutshell, in 20 minutes, whatever I could put, I have put here. And our ultimate goal is to have a healthy mother with a healthy baby. And we all obstetricians have been working towards the same aim. So I think ultrasound it will definitely help us to reach toward this goal. Thanks for patient hearing. Thank you so much.
Excellent talk, madam. As I told you, it was a very nice and precise. What I was expecting was you may say something about anemia in pregnancy, one of the medical disorder which is
I need
common
more
and very
time.
prevalent. Yeah, because here in rural area, I work day in and out for blood. And most mother are anemic, and the child and the abdominal circumference is less, or microsomia, and so many other things are there, which are there. But definitely these things are there. But even for that matter, obesity has come down over here from cities to the village. But your talk was excellent. Anybody having any question, may please, or I don't know, I can hand over the mic to the moderator, Dr. Monica. Please take over. Dr. Monica, you can just take over. And
I think the other chairperson can make some comments, and whether anybody else, Dr. Varsha, do you want to make some comments here? Yes.
Yeah, as usual, it was an impactful presentation, Dr. Bela. I heard her yesterday also. Superb deliberation, and you have covered the major diseases like gestational diabetes as well as hyperthyroidism. I think this patient, I think post-operative, we should go for 48 hours or frequent TSH recording, because these patients goes hypo postpartum hyperthyroidism. That's what I've seen. So monitoring postpartum is very important. The last case was excellent, beautiful case, and well handled. Congratulations, Dr. Bela. It was really good. And Sneha, really good topic, and the CME as well. Thank you so much for making me part of this.
Thank you, dear. Of course, Bela has always, excelled in whatever presentation she is assigned to, and I'm very happy that with focused selection of the topics she has done full justice to her topics. Definitely, as Dr. Rajendra Chauhan said, that yes, anemia being the commonest, and of course, the Rh negative pregnancy, where you have the role of middle cerebral artery and all those.
I'll need a full talk on that.
Yeah, I know that. We are going to have some keynote address or oration from you. Not to worry, we will soon invite you for the same. And that was excellent. And over back to you, Dr. Monica, for further process.
Thank you so much, ma'am. After an exhaustive talk on ultrasound and medical disorders in pregnancy, we move on to our next session, that is session number 2, medical legal aspects of the medical disorders in pregnancy. Our chairpersons for today's session, Dr. Sanjay Nigudkar sir and Varsha Lahade ma'am. Dr. Varsha Lahade ma'am was past president of the National OBGYN Society, the zonal coordinator of AMOGS. She has been the organizing secretary of NOGS, the past joint secretary of IMA, and National Faculty of Justice. She is the director of Prayagraj Hospital, Nashik. We welcome you, ma'am, as the chairperson. Dr. Sanjay Nigurkar, sir, the president of the Sindhudurg OBGY Society and has been a practicing senior gynecologist of the same. We welcome both of you to please share this session and introduce our speaker, Dr. Rajendra Tiwari, sir.
I think Dr. Sanjay Nigurkar, we can see you here. Welcome to this program. And please, may we have the pleasure to hear from you. Please go ahead with the introduction of the speaker. Thank you. Please unmute. Dr. Sanjay, please unmute yourself.
Hello. Yeah, thank you, madam. Thank you for inviting myself and Shamita Birmoy for this session. Today's speaker is Dr. Rajendra Tiwari. Hello. Can you hear me, madam?
Yes, definitely. We can see you and we can hear you.
Yeah.
Go ahead, please.
He is Joint Secretary of IMA Maharashtra. And then he is a member of Medical Council and AMC Mumbai. He is ex-chairperson and secretary of OBGY Society and executive member of IAC and FOXY. That I request Dr. Rajendra Tiwari to take over. Hello.
Yeah. Thank you, Dr. Sanjay, for the kind introduction.
Sorry, actually, I was late in the thing and I couldn't read that small this thing.
No, that is medical legal cell of
yeah.
So it's okay. Thank you. With all stalwarts sitting here, my CV is so small to be elaborated in detail. Respected President Pardesi sir, chief guest of today's program, Dr. Dalal madam, my dear friend and young leader, Dr. Kalyan, who is the guest of honor for today's program, and the architect of today's program, Dr. Sneha madam, who has given me this opportunity to speak on this topic. With graceful hands to you, ma'am, this is a very good topic. I realized after you gave this topic to me. So I'll start with the, without wasting time, I'll start with the presentation.
Just request you to make it full screen, please.
Yeah, ma'am, same thing I'm doing. I'll start the slideshow so that it will become full screen automatically. Now it's full screen, now?
Yes.
Medical and surgical field, as we all know, friends, is advancing with leaps and bounds. And now, with the introduction of artificial intelligence in all the faculties, along with the medical fraternity also, now the dynamics of patient management are going to change a lot. There is one organization known as MBRES in UK, which is an organization which does confidential inquiries into the maternal death and morbidities and news reports. It is available in India also. Such agencies are available in almost all countries. So there is a report of that, which can be an eye-opener for people like me who used to take medical disorders lightly before, like Madam gave me this topic. They found that 2/3 of the deaths in women were with the medical comorbidities, like pregnant women. 2/3 of the pregnant women who were dying, the maternal mortalities, 2/3 of the maternal mortalities were due to some medical morbidity associated with the woman, not pregnancy, not direct cause. And 30% of them were actually obese people. They were obese. So considering this, we can see that the magnitude of problem is big. There is one more agency called Intensive Care National Audit and Research Center, which analyzed the admission rate to critical care from 2009 to 2012. And they found alarmingly that 290 per 1 lakh were admitted to a critical care unit out of 11 MMR in the same period in UK. The MMR is less over there. So 11 MMR was there, and out of these 290, majority of the women who expired were from this critical care unit, which again shows that the magnitude of problem and the causes of death is indirect more than direct. Now this is again the graph. This graph is visible now, ma'am. This graph is visible now.
Yes.
Here it is blurred. So this is the graph which shows, if we carefully see, that the indirect causes are rising and the direct causes like bleeding, etc., are going down. This is the study of maternal mortality from 1985 to 2012. And it has been constantly seen that gradually the causes of indirect indirect deaths are contributing more to the maternal mortality compared to the direct deaths. I mean the indirect due to some morbidities. Now coming to our branch, it is obstetrics. It is a vulnerable branch. This is a study from ACOG now. ACOG questionnaire was thrown to all the members in one seminar, and this it was a big study actually. And this decision was taken, this data came out. Average, an obstetrician is 2.5 times more liable for any legal suits compared to any other counterpart. 80% of the obstetricians, they have got a chance to get sued at least once in their lifetime. They found that 80% तो एक बार कभी कभी केस हो ही गए उस पे. 25.6% obstetricians reduce their high risk obstetrics gradually. Eclampsia है नहीं लेने का, GDM है और किधर ढकेल देने का. So this kind of tendency उन्होंने दिया 25.6%. I think it is in our India also it is not less. We are also pushing our responsibility. अरे GDM है कौन लेगा चलो और किधर भेज देते. 7.2% quit practice altogether. Total obstetric practice बंद कर दिया था. It was a news also in USA. One time had come from one state. सब लोगों ने obstetrics छोड़ दिया था. And 28.5% they retort to increase in the LACS, and many around 26% they retort to not doing VBSC, that is vaginal birth after cesarean section. So they totally resort to not doing VBSC. Now who are prone? It is a very big topic in itself. Which doctors are prone? Actually, it is a bad luck. Many doctors are prone. Anybody can face any problem and court case can occur. Now, Amit Shah ji has said, but it is going to take time to decriminalize it. It is going to take time. वो decriminalize हो सकता है, लेकिन litigation free नहीं हो सकता है. तो consumer और civil cases तो consumer आने से पहले भी civil cases हुए, तो civil cases तो होंगे ही. But there are certain categories of doctors who are more prone for litigation. That is hurried doctors. हरी वरी और करी, ये तीन चीजें लाइफ में डिफिकल्टी पैदा करती है और सभी के करती है, डॉक्टर के भी करती है. If you are hurried, if you are not interested in matters of the patient, if you are lacking empathy and sympathy about patient and their matters, unwilling to answer questions of the patient to their satisfaction, lack of communication. Now communication has 80% body language, 20% what you speak. So that also matters, how you are sitting, how you are speaking and all. And always one should document what you are communicated and communicate what you are documented. So whatever has been documented should be communicated, and whatever has been communicated should be documented, and that is important. And that sometimes doesn't occur, and that leads to the litigation. And overworked doctors are also the doctors who are more prone for litigation. Exhausted doctors, overworked doctors are more prone for litigations. Now, why obstetrics is more prone? There are many reasons again. Some doctors are prone and obstetric is as such prone. So why it is prone? Because of 4 reasons I find that obstetric is more prone for litigations compared to, or more vulnerable for litigations compared to other branches. Of course, anesthesia is also one of the branch, but obstetric is more vulnerable because dealing with 2 lives. We are dealing with 2 lives, out of which one is obviously to monitor. Mother ko to obviously pulse BP leke monitor kar sakte. But a fetus is not visible, so it is difficult to monitor the fetus unless we take a stethoscope and put on the abdomen of the mother. और उसमें भी फिर स्टेथोस्कोप फॉल्टी हो सकता है, और ears can be faulty, even there can be crowd. So there are so many factors which prohibit us from directly monitoring the neonate, the fetus, sorry. But there are different modalities like machines, NST, Doppler, but that machine again, they have their own limitations. So there can be difficulties or there can be errors in monitoring the fetus. Another is the patient or pregnant woman, a pregnant mother. She is in your follow-up for about 46 weeks, 40 weeks of pregnancy, 6 weeks postpartum. So 46 weeks में the dynamics and the physiology changes a lot, which patient fails to understand. Obstetricians deal with physiology as such, and hence in case of unfavorable outcome, कोई अगर lady है 40 year and उसको MI बैठता है, and they take to the physician's ICU, she is not pregnant, then they are prepared. Everybody is prepared कि MI बैठा है मतलब बोल नहीं सकते. So they are prepared for any untoward incidents. But the same lady, unfortunately, if she is pregnant and she develops MI in a nursing home of an obstetrician, then it is not acceptable. Just wait a minute.
You can click on the slide once.
Yeah. No, that is not there. One bar was coming which was prohibiting my slides. The patients, the obstetric patients are usually young and healthy, as I already told, and the patients, the relatives are not in the mood to accept any untoward incidences. Now, areas of potential litigation that I have divided into two categories. One category is general, another category is potential litigations in the medical disorders. Now, antenatal care for high-risk patients is as such an area which is potentially prone for medical legal problems, because as Bella madam said just now, certain points have to be seen. You have to predict the PIH in prior. You have to predict. You have to anticipate GDM. You have to diagnose GDM. So all these things are there which has to be done. If it is not done, it is act of omission, and one can be liable for the suit. Errors or omission in antenatal sonography screening and diagnosis are definitely something which is liable for suits if it is not done properly. Preterm labor, though, if it is not predicted and some high hopes and unfortunately if the neonate expires in the NICU or something like that, then always it is a prone for litigation. Antenatal injuries, vaginal instrumental deliveries, LSCS, perineal tears. Recently, there was a case of hematoma and rectus sheath where a notice has come to one doctor. So there are so many cases are coming up now. Litigation, we are in negligence committee of Palghar district. So many cases are coming now. The cases have rise. Perinatal deaths, IUFD ho gaya, stillbirth, neonatal deaths not acceptable. Birth asphyxia, so many cases now. We'll go through some cases. Neurologically impaired infants. Whenever this happens, we are liable for suit. We should be ready with our notes and mentally prepared. Postpartum hemorrhage, obviously, it is one of the cause where there can be a morbidity as well as mortality. So again, it is one of the reason where we can get suit. And retained swabs and tampons in the vagina or tampon. Sometimes a roller gauze can be kept in the uterus, which can be forgotten or difficult to remove, left, or something is left in the uterus. So that can also be a part of gross negligence, and we are liable to compensation. Now, another potential areas are related to the medical disorders, which is thromboprophylaxis. Say, koi SLE case hai, koi thrombophilic patient is pregnant and we are failing to identify it, and even after identification, we are failing to give thromboprophylaxis. Then it is considered as act of omission, and again you are liable. Drug-induced teratogenicity. Obviously, everybody knows. Blood clots, blood not booked for a patient of bleeding PB or placenta previa. Vertical transmission of HIV to neonate is it cannot be prevented completely, but if it is not efforts to prevent it are not done, then also it can be considered as a act of omission, and it can be one of the reason for medical suit. Obstetric sonography, as just now we listened to the lecture of Dr. Bela Bhatt, if it is not properly done, litigation prone field hai. So it's better that we do sonographies to a primary level and we take an opinion from the fetal medicine specialist, and we will share our responsibility. Missing anomalies and overdiagnosis, even underdiagnosis as well as overdiagnosis on sonography is one of the potential areas where one can undergo the suits. Now, heart disease in pregnancy is, if you miss heart disease, it is again act of omission, you are prone for litigation. Heart disease accept कर लिया, instrumental delivery किया कट शॉट करने के लिए, tear हो गया, forceps लगाया, tear हो गया, that also can lead to perineal tear हो गया, CPT बैठ गया, that can also lead to there is one of the potential area. Hypothyroidism in pregnancy, I had one case where 12.5 microgram thyronam was prescribed by obstetrician, and pharmacist gave 125 microgram. Because of his busy schedule, obstetrician ने चेक नहीं किया. 1 month के बाद patient को hyperthyroidism हो गया. Patient went into preterm labor at 26 weeks. We don't know, it can be preterm labor, what to call it. But unfortunately, outcome was bad, and there was a notice to the doctor. Why didn't you see? Because you have prescribed, you are the person who is responsible for the dosing, so you should have seen. Now, the 110 cases of CP, cerebral palsy, were analyzed in one study where in UK, where 70% claims in UK for CP. Out of 110, 70% claims were based on CTG interpretation. Now, fortunately, we are doing NST CTG and not for continuous monitoring. Many hospitals, small hospitals, they are not doing. On admission, we are doing NST or CTG. Later on, we are not doing. But many centers, they do CTG like for a long period, and the recordings are supposed to be kept preserved, and they are now liable for interpretation of the same CTG recording in the other centers or by the committee. So many in UK, 110 में से 70% claims सिर्फ CTG बराबर interpret नहीं किए इसलिए हुए. And VBAC obviously is one of the potential area for litigation. कि आप लोग VBAC कर रहे हो, पिटोसिन लगा दिया, आपने सिंटोसिन लगा दिया, सरीप्राइम कर दिया, और बाद में उसमें ऐसे केस भी है. Just come to that case also. Now, there is confidential inquiry into stillbirth and deaths in pregnancy, where this is from UK. So they found that 50% of these deaths were avoidable. At somewhere इसीलिए ऐसे लेक्चर्स अटेंड करना चाहिए जहाँ पे नियर मिस चीजें पता चलती है, और मेनी टाइम्स वी फेल टू take decisions in time, and that can also lead to some unavoidable mishaps. Now, these are the different medical disorders in pregnancy, which I don't need to elaborate because all are esteemed gynecologists, everybody knows this. Just to complete the list, I have put this slide. Now, litigation process, obviously, किसी को notice आया तो भी उसको रात में नींद नहीं आती, इंसोम्निया हो जाता है. अब ये तो अगर लिटिगेशन हुआ, कोर्ट में गया, कभी किसी को इम्प्रिजन में बैठ गया, तो उसको डेफिनेटली इट इज अ पेन, सफरिंग, डिस्ट्रेस, एंड इट इज अ लॉस ऑफ रेपुटेशन. Now, this is again a chart which shows that the same thing which I said in the beginning, ki gradually the causes of death are shifting towards the indirect causes like cardiac diseases, non-genital sepsis, thrombosis, neurological, psychiatrist. You can see indirect causes जो दिखा है ना, वो ज़्यादा अभी आजकल they are on rise. So we need to know what are the disorders and how to treat them. Now we'll go to cases. What cases were there and what we learn from the cases. This is a case from National Consumer Redressal Forum. Dr. Indu Sharma was a BMS doctor. She was obese and she was patient of Dr. Sohini Verma. Sohini Verma madam was a gynecologist and Dr. Indu was under her for antenatal care. She was admitted to Indraprasth Apollo Hospital, Delhi with PROM. It is a case of 99. That time she was admitted in Indraprasth Apollo Hospital in Delhi with PROM, middle of the night, 11:30. But unfortunately, that time the patient was not seen by Dr. Verma and the patient was seen by some another RMO. And in the morning, Dr. Verma came, she saw the patient and she gave Cereprime gel. Cereprime gel देने के बाद patient started contraction. And CTG monitoring was there, continuous CTG monitoring was going on. And the patient being doctor, she found that उसमें drops आ रहा है. हार्ट बीट्स 80 तक जा रहा है, ऐसा वो पेशेंट को लगा. पेशेंट ने डॉक्टर को बोला गायनेकोलॉजिस्ट की हार्ट बीट्स नीचे जा रहा है. तो गायनेकोलॉजिस्ट ने बोला ठीक है, थोड़ी देर के लिए पिटोसिन रुका देते, लेफ्ट लैटरल देते, एंड अगेन शी कंटिन्यूड पिटोसिन. एंड इन द मिडल ऑफ अनदर नाइट, आफ्टर 27 आवर्स, इन बिटवीन गायनेकोलॉजिस्ट ने कहा कि सोनोग्राफ अपना सीजर करेंगे, बट शी वाज नॉट एग्रीइंग. So after 27 hours, they did cesarean section and the asphyxic, the fetus was born, unit was born. उसको resuscitate किया गया. It was admitted in the NICU and discharged after 15 days. Mother was discharged after 4 days, but the fetus was discharged after 15 days. और उसके बाद 2.5 months के बाद fetus को seizures, epileptic seizures आने लगे. Then they went to another hospital and there it was found that the CT scan EEG was done and it was found that the fetal brain is atrophic. And milestones of that girl was that was a girl child. Milestone भी उसके delayed थे, and unfortunately at the age of 12 years that child expired. Poor child expired. So now this doctor's brother was in USA and he was a pediatrician. तो उसमें ओपिनियन लेके उसने केस किया और एम्स कमिटी ने भी इसमें नेग्लिजेंस प्रूव किया. एंड दिस वाज वन ऑफ द एलिगेशन वेयर 2.5 crore कॉम्पेंसेशन वाज एक्सपेक्टेड, डिमांड किया गया था, और 1 crore कोर्ट ने दिया है उसको. ये कब दिया है? 2015 में दिया है. नाउ इस long back, 8-9 years. So now they can easily give 2 crores. So LSCS was not done in time. What were the allegations of Dr. Indu Sharma? LSCS समय पे नहीं किया गया. सिंटोसिन डोज एक्स्ट्रा दिया गया. एक्सेसिव डोज वाज गिवन. ड्रॉप्स आ रहे थे फिर भी मेरा सुना नहीं. None attended the patient immediately. रात में कोई पेशेंट को देखा ही नहीं गायनेकोलॉजिस्ट ने. And hospital falsely assured them all reports were normal. हमने पूछा तो हमको बोला नहीं सब कुछ नॉर्मल है. These were their allegations. One, as I already said, 1 crore award किया गया. They were demanding 2.5 crore. उसमें से 80 lakh अपोलो ने दिया, 20 lakh डॉक्टर वर्मा ने दिया. टोटल बिल वाज 1.5 lakh रुपीस बिल था. उसमें से 25,000 सिर्फ डॉक्टर के थे, तो डॉक्टर ने दिया 20 लाख. एंड दैट टाइम आई डोंट थिंक दैट मच the indemnity the doctor might be having. So the thing should not be taken lightly. This patient was obese, so might be to avoid cesarean section, the doctor might have given a little more induction and more trial of labor. Now another case is of mismatched blood transfusion. As Dr. Rajendra said, anemia is common, so anemia है तो हम blood transfusion करेंगे. So there is a case of PGI Chandigarh. It is not an obstetric case, but in court सब डॉक्टर एक ही तराजू में तोले जाते हैं. They precedent करके जो भी केसेस सुप्रीम कोर्ट में जजमेंट हो गई है, that cases, it is basically a law of tort. When a court gives judgment for doctors, it is a law of tort. It is not a criminal law. So civil law है, law of tort. So law of tort में क्या होता है? Whatever judgments are given by the court, Supreme Court, High Court, they are taken as a precedents. So it is a judge-made law. जैसा आईपीसी होता है जो उसमें ऑलरेडी देर आर सेक्शंस. तो व्हाट इज क्राइम, what is the definition of crime? For example, murder. The definition of murder is defined 302 उसमें क्या punishment देने का है. So such penal codes are not defined in civil law. So whatever court gives decision, Supreme Court or National Consumer Redressal Forum, that are taken as precedents, and depending upon them, depending upon those judgments, further judgments are given. So ये judgment obstetric के है भी नहीं, तो ये judgment को precedent करके use किया जा सकता है अपने cases में भी. That's how I included the judgments. Now this is a case of PGI Chandigarh versus Jaspal Singh. Supreme Court judgment at 29th May 2009. Jaspal Singh's wife suffered burns, 70-80% burns. She was taken to a private hospital. 2 days she was kept there. According to Mr. Jaspal Singh, she was responding, but because they were unaffording, they went to PGI Chandigarh. वहाँ पे patient को रखा गया, but patient was anemic also. So she was transfused with blood, and after blood transfusion, unfortunately, the blood transfusion was of another group, and she developed reaction. According to the patient, it was of another group. According to the doctors, it was the same group. तो रिएक्शन आने के बाद उसको कंट्रोल किया गया. पेशेंट सर्वाइव्ड द रिएक्शन, एनाफाइलेक्सिस ऑफ द ब्लड, बट आफ्टर 40 days द पेशेंट एक्सपायर्ड ड्यू टू septicemia. Now in this case, the patient's take was that the patient died due to mismatched blood transfusion, and therefore the compensation should be given. The doctors of PGI Chandigarh were of the opinion that obviously there was a blood transfusion reaction, no doubt, but the patient survived after that for 40 days. Total 40 days he survived. So the cause of death was not actually mismatched blood transfusion, but cause of death was septicemia. The lower courts ने डॉक्टर को पनिशमेंट दिया, उनको compensation award किया, but Supreme Court they acquitted the doctor. So Supreme Court accepted that the death, direct causal relationship between the death and the blood transfusion is not established. इसलिए benefit of doubt रखते हुए कोर्ट ने इनको इसमें से acquit कर दिया. Now another case of mismatched blood transfusion is Dr. Iqbal Khan versus Child Trust Hospital. Blood transfusion के cases मैंने इसलिए लिए हैं because we also transfuse blood. Anemic patients, they are common, especially in the rural areas, and one should know what kind of judgments are given in these cases. Dr. Iqbal Khan was managing Child Trust Hospital in Kerala. That time a 6 months old baby उसके पास आ जाता है, and that baby is B positive, and that baby was suffering from hemolytic uremia syndrome. We know as such the prognosis of hemolytic uremia syndrome is very less. As such the neonate expires. So what he might have thought कि already the neonate is anemic and sinking. We don't have B positive. Let us AB positive नहीं है तो B positive transfuse कर देते हैं. He transfused B positive because AB positive was not available, and the neonate sunk and expired. After that, the lower courts convicted Dr. Iqbal Khan. But Supreme Court, he acquitted Dr. Iqbal Khan because at that time the blood was not available and he did whatever he could have done in that situation, was the opinion of Supreme Court. Hepatitis C transmission, as you all know, there are famous hospitals, reputed hospitals in Mumbai also who have been, penalized by the courts. There are cases where doctors and hospitals have been sued, awarded compensation by courts prior to blood transfusion. Blood transfusion के बाद hepatitis C हो गया. Not because of the blood transfusion, the causal relationship was not established. लेकिन फिर भी compensation दिया गया because poor paperwork. Of diabetes, as we know, GDM diagnosis is now necessary because we have to screen. We can't come to a clear-cut diagnosis in IGTs and borderline diabetes. In that case, delay in the diagnosis and suboptimal treatment of diabetes can lead to compensation. This is the case of PK Sinha versus Dr. Mani Bhargava. It is National Consumer Redressal Commission. 13 जुलाई 2011 का केस है. The doctor couple के पास पेशेंट रात में आ जाता है, कोमाटोस पेशेंट, और वो लोग उसको कोमाटोस पेशेंट करके ट्रीट करते हैं, बट दे नेवर डू ब्लड शुगर रात में, एंड दे डायग्नोस, दे डू ब्लड शुगर अर्ली इन द मॉर्निंग बाय 10 o'clock समथिंग, और डायग्नोस लेट होता है, तो कीटोएसिडोसिस डायग्नोस नहीं होता है. दे आर मैनेजिंग दिस लाइक एनी अदर अनकॉन्शियस पेशेंट. तो बाद में डायग्नोस होने के बाद दे रेफर द पेशेंट टू सम अनदर हॉस्पिटल, वेयर इन द ज्यादा नहीं, द पेशेंट रिजल्टेड इन द पेशेंट्स डेथ. So because of that, compensation was awarded by the court. You delayed the diagnosis. Had you diagnosed the patient in time, the patient would have survived. The same yardstick can be used if we are not diagnosing GDM and something happens to the patient. Diabetes with septicemia, again, it is very common. GDM patient को भी septicemia हो सकता है. This is a case of Josna Bani Ghosh versus Mr. Sanjukta Curatives. नर्सिंग होम है, उसका नाम क्यूरेटिव्स है. ये भी केस है, डायबिटीज विद यूटीआई है, सेप्टिसेमिया है, and it is being treated by Dr. Baidinath Mishra. द पेशेंट का तो सब कुछ ठीक है, लेकिन मॉनिटरिंग वाज डन बाय नाइट ड्यूटी स्टाफ वाज अ फार्मासिस्ट। तो पेशेंट का टेक ये था कि नाइट ड्यूटी में मॉनिटरिंग वाज नॉट डन बाय क्वालिफाइड पर्सन, इसलिए हमारा प्रॉब्लम हो गया, पेशेंट एक्सपायर्ड। In that also, the lower courts, Baidyanath Mishra was convicted and penalized in lower courts, but Supreme Court acquitted him. Heart disease में अभी एक interesting judgment है. This judgment I have put because there is something known as cross-pathy among us also. अभी हम लोग sonography करते हैं. Many radiologists feel it is a cross-pathy only. So Dr. N.K. Jain was a physician. This is a case of Dr. N.K. Jain versus Mr. S.C. Gupta. It was National Consumer Distress Commission 8 जनवरी 2015 का केस है, रिसेंट है, बहुत पुराना नहीं है। चेस्ट पेन का पेशेंट आ जाता है डॉक्टर जैन सर के पास, ही टेक्स ईसीजी और कुछ मेडिकेशन दे देता है, पेशेंट ठीक हो जाता है। आफ्टर 6 months अगेन पेशेंट डेवलप चेस्ट पेन और वो पेशेंट HGPGI लखनऊ में एडमिट हो जाता है, वेयर द पेशेंट इज डायग्नोस्ड विथ मायोकार्डियल इंफार्क्शन, IWMI मीन इश्केमिया विथ मायोकार्डियल इंफार्क्शन। अब वहां पे कोई कमेंट पास कर देता है कि यार ये पेशेंट को 6 महीना पहले ही थ्रोम्बोलाइज किया रहता तो शायद आज इधर एडमिट नहीं हुआ रहता है, उसका CAPG नहीं करना पड़ा। तो बिकॉज ऑफ दैट पेशेंट गोज इन ऑफ कोर्स कोर्ट ऑफ लॉ, और बाद में कॉम्पेंसेशन डॉक्टर जैन इवन आफ्टर बीइंग MD मेडिसिन उसको 50,000 रुपए का कॉम्पेंसेशन देना पड़ा वो केस में। तो हम लोग भी कुछ फिजिशियन तो है नहीं। If you are treating diabetes, if you are treating some cases of heart disease without involving other people who are qualified in that field, we can also face such problems. ना अभी ये है कि मैं बोल सकता हूँ मैं तो गायनेक हूँ, यहाँ पे व्हीकल और एक्सीडेंट का पेशेंट है, यहाँ पे कोमेटस पेशेंट है, मैंने लूंगा मैं गायनेक हूँ और डायरेक्ट मैंने उसको बैट कर दिया। सो व्हाट आर द लॉज रिगार्डिंग इट? बहुत सारा होता है ना कि रोड साइड हॉस्पिटल्स होते हैं गायनेक के, कोई व्हीकल और एक्सीडेंट हो गया वो लेके पहले गया, उनको क्या पता रहता है कि गायनेक, अरे मी तर गायनेकोलॉजिस्ट आहे, मी पेशंट बघणारच नाही। तो कॅन वी से लाइक दैट? नो, वी कांट से लाइक दैट, बिकॉज देर इज वन जजमेंट फ्रॉम सुप्रीम कोर्ट which is known as a famous judgment, which is known as Pandit Paramanand Katara versus Union of India. It is very interesting case. Pandit Paramanand Katara was a social activist. उसका ये केस से कुछ लेना देना नहीं है। He was reading newspaper with the tea in the morning with breakfast. He came across a news. न्यूज़पेपर में पंडित परमानंद कटारा एक न्यूज पढ़ता है कि एक कोई टीनेजर बॉय ही सफर सम एक्सीडेंट्स। एक्सीडेंट होने के बाद ही इज टेकन टू एक्स हॉस्पिटल बोलता है कि हमारे को एक्सीडेंट का अनुभव नहीं है, आप वाई हॉस्पिटल में जाओ, वहाँ पे पूरा फैसिलिटी है। उसको शील्ड किया जाता है कुछ बिना गिविंग एनी ट्रीटमेंट नथिंग। वाई हॉस्पिटल बोलता है हमारे पास है फैसिलिटी लेकिन डॉक्टर नहीं, आप थर्ड वो जेड में चले जाओ। जेड में जाने तक पेशेंट एक्सपायर हो जाता है और जेड ब्रॉड डेथ डिक्लेयर कर देता है। तो ये न्यूज किसने पढ़ी? परमानंद कटारा इज नॉट नोन टू दैट पेशेंट। ही वेंट टू सुप्रीम कोर्ट एंड फाइल्ड द लिटिगेशन कि ऐसा नहीं होना चाहिए। व्हेनेवर अ पेशेंट कम्स टू एनी डॉक्टर, ही इज प्राइमरीली MBBS, he should try to give some supportive management treatment and give some basic treatment and ABC ट्रीटमेंट जो होता है, एयरवे होता है, तुम्हारा ब्लड वेसल सिक्योर करना है, वो सब करके देन ही शुड रेफर द पेशेंट। सो दिस इज द क्लियर कट गाइडलाइंस। आफ्टर दैट गाइडलाइंस हैव बीन गिवन टू ऑल द हॉस्पिटल्स एंड वी कैन नॉट से कि हमारा ये केस नहीं है। बोलना भी है तो यू शुड बी वेरी डिप्लोमेटिक। अनदर केस ऑफ सिमिलर वैरायटीज, पश्चिम बंगाल खेत मजदूर समिति एंड अदर्स वर्सेस वेस्ट बंगाल। ये और पुराना केस है, 90s का केस है। तो ये केस उसमें पश्चिम बंगाल मजदूर समिति है ना, दे हैड गॉन टू अगेंस्ट वेस्ट बंगाल गवर्नमेंट कि ट्रीटमेंट हर एक की होना चाहिए, इज पुअर दैट्स व्हाई दैट पर्सन डाइड। तो हेल्थ इज अ सब्जेक्ट मैटर ऑफ स्टेट। तो स्टेट का ड्यूटी है कि स्टेट में जितने भी सिटीजन्स है दे शुड नॉट डाई बिकॉज ऑफ डिसीजेस ओनली बिकॉज दे आर पुअर। सो राइट टू हेल्थ was included as Article 21, right to life, and in that state was held responsible. तो स्टेट अपने हॉस्पिटल पूरे स्टेट के साथ एक्रेडिटेड है। तो इसलिए whenever any patient comes to us, even if that patient doesn't belong to our faculty and that patient is serious dying, it is our duty to give primary management and then we can refer the patient. Now CCU and ICU management and law. Medical errors are most common type of errors, and studies have shown that about 78% of the medical errors occur in ICU. There are so many errors occurring. दूसरा ही ड्रग ये साउंड alike, looks alike drugs are being given. If it mepentin बोला, मेथेरिजिन बोला, मेपेंटिन दे दिया, it is not uncommon. So these kind of errors are not seen by the patient. Patient तो वहाँ पे कोमेटोज होते हैं, अच्छे सेमी कॉन्शियस होते हैं। तो सिविल और कंज्यूमर केसेस में एक इधर पेच ऐसी है कि अगर कोई अपने पे एलिगेशन करता है, XYZ कर मेरे पे एलिगेशन करता है कि डॉक्टर तिवारी ने सो मेरे पेशेंट को OPD में ऐसा नहीं देखा, तो इट इज ही इज ओनर्स टू प्रूव इट बिकॉज ही इज कॉन्शियस, वॉकिंग करते हुए मेरे पास आया, ट्रीटमेंट लिया, वापस गया। But same patient in ICU, he is alleging me, it is my onus to prove because वो उस पे onus नहीं रहता है. So plaintiff पे onus इसमें नहीं रहता है, इसमें defendant पे onus रहता है, इसमें ICU में. So whenever the patient is in CCU, critical care unit, obstetric CCU, you have to be more careful because the onus is on you to prove, disprove, not the onus is not on him to prove. Now this is no ICU, no surgery. You might have heard this case. There are two cases. एक तो अभी बीदर कर्नाटक का रिसेंट केस है पिछले साल का ही, और एक वेस्ट बंगाल का केस है. पेशेंट, एक केस वेस्ट बंगाल का 1993 का है, हिस्टेक्टोमी किया. आई थिंक उसके लिए समय लगा रहेगा. दे हैव गिवन GA फॉर हिस्टेक्टोमी एंड पेशेंट डिडंट कम आउट ऑफ GA. तो पेशेंट को रिवाइव करने का कोशिश किया गया. पेशेंट वाज ट्रांसफर्ड एट मल्टीपल सेंटर्स, बट अनफॉर्चुनेटली पेशेंट एक्सपायर्ड. इन दिस केस द कोर्ट, सुप्रीम कोर्ट हेल्ड that doctor is apparently not negligible. Negligence has not been proved, but even though there was no ICU, so compensation was awarded, and that was of 5 lakhs in 1993. It
Beautiful
is not
cases,
less
Dr.
amount at that time.
Dr.
One more
Rajendra,
case,
beautiful
all known
cases.
Sindhudurg case.
We have to see the time also.
Yeah, हो गया madam. Okay.
Yeah, okay.
How many?
Okay.
How many? 2 minutes? 3 minutes? 2 minutes?
1 minute, 1 minute, sir. We have to
Okay.
wind up.
Bidar case. Okay,
Yeah.
ma'am. Bidar case is of 6 January, wherein hysterectomy patient expired, and the court, the lower court gave, punishment, not only punitive punishment, but they gave 2 years jail. Now the minimizing, how to minimize awareness, ignorance is not ignorance. You should be aware. Patient, while history taking, you should be good listener. Good interprofessional relationship should be there. Proper counseling should be there. Upgrade skills in the management, you should be upgrading. ऑब्स्टेटिक छोड़ के दूसरे भी स्किल्स थोड़ा एक्वायर करने चाहिए, जैसे इंट्यूबेशन होता है, लैरिंजियल मास्किंग होता है. अवॉइड इंटरप्रोफेशनल जॉस्टिंग. बी लिबरल इन इन्वेस्टिगेशंस, उसमें पेशेंट का पैसा बचाने का मत सोचो. एसोसिएट विद कलीग्स विद इंटेंसिव फिजिशियन, टेक रूटीन सेकंड ओपिनियन फ्रॉम देम, एंड मल्टीडिसिप्लिनरी अप्रोच शुड बी देयर. डिसीजन ट्रांसफर का बहुत समय पे लेना चाहिए, एंड टास्क फोर्स शुड बी डेवलप्ड अमंग आवरसेल्फ टू हेल्प इन सच केसेस. ड्यू डिलिजेंस शुड बी डन, and this is a graph which shows how to work in the team. And ultimately, obstetric is a unique specialty involving multi-professional, multidisciplinary working, and this require effective communication, team working to optimize patient care. Thank you very much. Thank you, ma'am, for giving 1
Yeah,
minute.
thank you so much, Rajendra sir.
Thank you.
Being me and you are same public health department, I think we are near to each other by thoughts.
Yes, ma'am. Yes.
As really exhaustive presentation and beautiful cases as well, and he has given a right message that from the each case there is a learning lesson from his presentation. I have few things to tell. As you are in the negligent committee, our
Yes, ma'am.
fraternity is very, very small and very susceptible. So please try to save our doctors. One message. The second, whatever you do, whatever you have, whatever your faculty is, you are under medico legal litigations all the time. म्हणजे तुम्ही जात्यात आहात. Everyone out here or everywhere, doctors. And for that, फक्त एवढंच मला म्हणायचं की everyone should try to not to comment any other doctor. One. Second, आपण छोटे comment सुद्धा it makes a lot of difference to the relatives. आणि always go to the help of our own fraternity. म्हणजे it is very easy because कुणावरही केस टाकल्यानंतर पहिला FRI व्हायच्या आधी मेडिकल बोर्डाकडे जातोय. दिस वी नो. Whatever Amit Shah said, we have not enlightened with his things. पण त्याच्या आधी मेडिकल बोर्डाला एथिकल आणि प्रॉपर हे करताना रिपोर्ट देताना फक्त आपल्या फॅटर्निटीकडे बघा. सेव्ह आवर फॅटर्निटी. द ओनली मेसेज आय वुड लाईक टू गिव्ह. थँक यू सो मच.
Thank you.
Yes.
Monica, over to you. Yeah.
Thank you, Varsha ma'am, for an excellent feedback of the talk. And Rajendra sir, it was a lecture.
One
which
minute,
covered
Dr. Monica. Doctor,
Yes,
if
sir.
I can talk. Actually, Dr. Rajendra has given a very, very good talk, but I wanted to ask certain pertaining question to our faculty. Like there are questions when you are treating a previous cesarean section patient or post-dated patient, or nowadays we are giving IV iron. So I thought rather than general these cases, if we had talked, So that was some, I think, point of reference in our practice.
Time constraint is there, sir. I had
Yeah.
tried to include this, but time फिर हर cases मुझे discuss करने थे. See,
Yeah,
like treatment part, everybody knows over here better than me. I wanted to just
Yeah.
highlight the cases.
Yeah, we are now practicing in rural area. It has become really difficult, like
Yeah.
maintaining counseling well, then maintaining the notes, and at times it does not happen possible. And then like present era, if we apply all the urban this thing criteria here, it becomes difficult
Yeah,
to practice.
Dr.
Then
Sanjay, if I can just talk only 1 or 2 sentences about this. You have raised a very pertinent question, I would say. Recently, I had delivered a talk about communication skills at the state conference of IMA, and there I have highlighted mainly on the communication and documentation. The conclusion of the talk, I would just say that it's the body language of the doctor, basically. What are the basic communication? संवाद हा सुसंवाद कसा असावा मराठीमध्ये मी सांगते की आपल्याला डॉक्टर्सना हे जे प्रॉब्लेम्स होतात ना हे मेनली आपली ट्रीटमेंट चुकीची होते म्हणून होत नाही. बहुतांशी हे प्रॉब्लेम्स आपल्या संवादामुळे लॅक ऑफ कम्युनिकेशन किंवा कम्युनिकेशन गॅप किंवा मिसकम्युनिकेशनमुळे होतात. आणि म्हणूनच आपण कुठलीही गोष्ट ज्याच्यामध्ये मी डॉक्टर राजेंद्रनी ब्लड ट्रान्सफ्युजन इन्क्लूड केलंय, पण त्याच्यामध्ये मी एक ऍड करेल की एनी ड्रग फॉर दॅट मॅटर इन्क्लुडिंग अॅनास्थेशिया हे त्याच्यामध्ये जस्ट जोडलं ना तर ही स्टॉक विल बी कम्प्लीट. कारण की मेडिकल डिसऑर्डर्सचं आपण म्हटलंच आहे की कुठल्या मेडिकल डिसऑर्डर्स, जसं डॉक्टर बेलानी म्हटलं की तुम्ही जर हे प्रिडिक्टिव्ह मेजर्स, त्या टेस्ट, ते मेजर्स, ते प्रिव्हेंटिव्ह मेजर्स जर फॉलो नाही केलं तर तुम्ही लायबल आहात. जसं ऍक्ट ऑफ कमिशन आणि ऍक्ट ऑफ ओमिशन. तर आपण हे जर हे केलं नाही तर ऍक्ट ऑफ ओमिशन, आणि जर काही गोष्टी केल्या तुम्ही, जसं आता जे तुम्हाला मिसमॅच ब्लड ट्रान्सफ्युजन जसं आपण म्हटलं की इट्स ऍक्ट ऑफ कमिशन, तर अशा काही गोष्टी ज्या आहेत त्या आपण थोड्याशा क्लॅरिफाय करून घेतल्या तर डेफिनेटली व्हॉट यू आर सेइंग, आय गॉट युअर पॉइंट की अशा गोष्टी जेव्हा आपण आपल्याकडे जेव्हा प्रॉब्लेम्स होतात ना त्यासाठी तुम्ही त्या पेशंटला किती चांगल्या रीतीने कन्व्हिन्स करू शकता की तुम्हाला हा प्रॉब्लेम आहे ऑलरेडी, त्याचे हे प्रॉब्लेम्स आहेत, तुमच्या प्रेग्नन्सीवर किंवा तुमच्या बाळावर त्याचे हे इफेक्ट्स आहेत, तुम्हाला या ट्रीटमेंटची आवश्यकता आहे, या ट्रीटमेंटचे चांगले इफेक्ट्स तर आहेतच पण त्याचा हा साईड इफेक्ट पण राहू शकतो. आणि जोपर्यंत तुम्ही यासाठी तुमची संमती लेखी स्वरूपात देत नाही तोपर्यंत आपण हे लावू शकत नाही. थोडंसं आपल्याला स्ट्रिक्ट व्हावं लागेल.
पण कधी sometimes what happens even if when you are taking all these precautions, it happens that point sometimes miss out on small things and it can happen. Like Dr. Varsha said, now if Dr. Rajendra is in that committee, he has to be really sympathetic and has to understand, because sometimes it's a very difficult situation, and especially not only rural area, I'm saying sometimes that counseling is not done well and it leads to, but then there are special situations where both the things are possible. So if you have to do an error on the safer side. I think previous cesarean section, if you're giving trial, if you feel slightest case is not, then I think you better to go for section. Or even nowadays, I had one patient actually from my colleague where he had given IV iron, sucrose was given, and patient came with IUD and vasculitis. When I asked this to Dr. Karnik, he was KEM ICU head. So he was saying it's better to give transfusion than giving IV iron. Obviously, we will not agree to this. And now Dr. Karnik is head of Sion Hospital Medicine, this department. But then obviously, as what he is saying, that giving IV iron always has a risk. So in this situation, we don't know which is the drug which is completely safe. So this was the case. Another thing was, when we in rural area, we don't get trained staff. All staff. Obviously, this is a universal problem, I know. But that is another issue which I think needs to be addressed. Or then slowly small setups or small hospitals are going to turn into corporate hospitals, or it's going to become really difficult to practice with a small unit.
I think what I would suggest is rather what I have been following. Even I am practicing at a smaller town, Yavatmal. So that is now since 32 years. But what I would suggest here is follow the conventions, whatever your guidelines, your parent organization says. If you follow that, if you don't divert for patient's sake and for relatives' sake, I think that should protect you. So believe in your knowledge and implementation, believe in the law, and definitely that should sail through. Of course, your communication and documentation should protect you from all this. I think, of course, your doctor-patient relatives relationship, doctor-doctor relationship, and your relationship with the media, press, police, all these things have to be good. So all in all, I think communication should be the key to success to avoid all these problems.
Yeah, Sanjay, I would like to
Thank you,
just
madam.
add that.
Yeah.
Sanjay, I would like to just add that you should get your hospital Manyata accredited. That's wonderful and
Yeah.
very
Yes,
beautiful for the healthcare providers. And keep pace with Dr. Rajendra. I've told him on
Yeah,
the
that's very true. Yeah.
on the national platform, so he has
Yes.
to. Thank you so much,
Thank you.
Rajendra. It was really wonderful,
Okay.
wonderful.
Wonderful lecture, doctor. Yes.
Thank you, thank you. Over to you, Monica.
Thank you, ma'am. Thank you for an excellent feedback over the talk. Documentation, and documentation. This is the only thing that we can look forward to for the having a litigation-free practice. We now move forward to the next session, that is session 3, which is the panel discussion moderated by none other than Dr. Sneha Buyar, madam, on near cases in obstetric practice.
You can
madam
skip
has
this,
already
Monica,
been introduced.
please.
Yes,
you can skip this, yes.
Yeah. Let me take privilege to introduce our panelist for today, Dr. Nilofar Punawala. She is the director of the West Coast Multi-Speciality Hospital at Dhanu. She is a senior obstetric gynecologist. Dr. Kanchan Madar is a consultant and founder president of WSW. She has been awarded the Mrs. Universe Philanthropy and Mrs. Universe Central Asia. She is also the Global Changemaker Award winner. We welcome you, ma'am. And she's recently completed her LLB. Dr. Amrita Rawal is the director of Renu Women's Hospital and Birth Care at Boisar, and she began her career with volunteering her work in Western Africa and tribal areas of India. We welcome you, ma'am. Dr. Pushkaraj is an alumni of Grand Medical College, and he is practicing in DND Holy Family Hospital, Mumbai. He's currently practicing as an OBGY at Rajeshri Hospital, Palghar. We welcome you, sir. Dr. Ashwini Inge is practicing gynecologist at Dahan. Dr. Supriya Rudrapol is a practicing gynecologist from D.Y. Patil Medical College, Kolhapur. She is also serving as an honorary gynecologist at the Sub-District Hospital, the LKR College, and the Sugar Factory Hospital at Gadhinglaj. She has been a faculty at various conferences in the live laparoscopic surgical workshops. We welcome you, ma'am.
Thank you.
Dr. Neeta Gangude, madam, is a practicing gynecologist at Boisar. Last but not the least, Dr. Shamita Birbole, madam, she's a consultant and fertility specialist. She holds a diploma in urogynecology and pelvic floor reconstruction, and she's the director of Guru Krupa Multi-Speciality Hospital. She also holds an ICOG fellowship in IVF and a clinical experience of 25 years. We welcome you, ma'am. Over to you, Sneha, ma'am, for
Thank you so much, Monica. And without much ado, I think I would straightway go to the panel discussion. Once again, I welcome all my panelists. I think Dr. Nilofar is traveling and Dr. Kanchan is also not able to join. So we may have to skip or transfer their questions to the next panelist. I just welcome Amrita Rao, Dr. Pushkaraj, Ashwini Hengne, Supriya, and Nita Gangode, and Shamita. So I hope you can see my slides, and so all of you will agree to me that, most of the times we feel that, rather not we, but the relatives feel that it is just a normal labor and normal vaginal delivery, but you don't know at what moment your patient, just land up into this catastrophe and she can go to the ICU. So, friends, we have been talking about maternal mortality rate, but there is just short of this mortality, there is what is called as severe acute maternal morbidity, which is the term coined by this WHO. And this term near miss, this we have borrowed from the airlines industry. It tells you the urgency of the situation, the gravity of the situation and the urgency of intervention it requires. So, what is this near miss? It is actually the critically ill pregnant lady or who is recently delivered, that is within 42 days, who would have otherwise died had it not been her luck and your good care on her side. So we have to actually share such cases, discuss them so that you can have the assessment of the quality of healthcare as well as you can have some points to share for improvements and interventions for the others also. So, maternal mortality rate we have been talking about, and it is 97 per lakh for India. For the first time, it has come below 100. So, we are happy for that. Kerala is 19 and Maharashtra is 37 per lakh. So, definitely we are very close to the SDG goals. But, friends, these are not just rates and ratios, numbers and figures. These are women and they have their own faces, which we obstetricians see them, during the phases of their agony, distress, and despair. And these keep haunting our dreams. I'm sure those who have faced it, ज्यांनी कोणी अनुभवलं असेल अशी serious patient, maybe just short of mortality or having a mortality, definitely would never forget that phase. So Ian Donald also expressed that looking back over the long clinical times, we just tend to take the success for granted, but it's the failure which stands out like keloid. They keep reminding you and it's the warning for the others. So this problem is definitely rising because I'm going to skip some slides which are theoretical because of this career mindedness, late marriages and obesity because of the lifestyle problems and the smoking and alcohol adding to it. Definitely the rising incidence of infertility, the increased ART and IVF procedures, and the associated complications of multiple pregnancies, the associated medical and surgical comorbidities, definitely, the rising incidence of cesarean section landing up into the placental problems has definitely worsened. That it has not only increased the incidence of such near miss, but also widened the spectrum. So friends, let us all learn together, be a good disciple, never stop learning because life never stops teaching you. So with this, we just go ahead with the first case here. We have this second gravida who has had previous one seizure 1.5 years back, and now she comes to you with a history of 7 days overdue. Her UPT is positive, and she says, "Doctor, I don't want this pregnancy. Want to go for termination with medical methods." So the doctor prescribes her the empty pills and just asks her to come back after 7 days whether she has aborted. She gives history of spotting only and giddiness, and I won't say fine day, one bad night she comes in a collapse state. The relatives bring her, and when you examine, you find that the pulse rate is 132, the blood pressure is only 17. She is severely pale. So, what is your differential diagnosis? I'm sure Nilofer has not joined. May I ask Dr. Supriya to go ahead with this case? What is your differential diagnosis for this case?
As this is a state case of post-section early pregnancy, and she had a spotting, and followed by all these signs and symptoms, it might be some ectopic or tubal abortion, which may get aborted, and adnexal mass with free fluid. She require immediate surgical intervention because she might be bleeding inside. It is a hemorrhagic shock, which tells us hypovolemia, then tachycardia and pallor. And we have to arrange blood as early as possible. And she should go in OT
Correct.
immediately.
Yeah. But then how do you explain the differential diagnosis? Because she has had just early pregnancy and now she's in shock. So suppose you are from a small town and ultrasound is not available. You have to really struggle for the late night ultrasonography. How do you explain this? Whether you should have gone for, now we will think about the management. As you said, she needs to be resuscitated first. Her blood pressure is only 70 millimeters of mercury systolic. Okay,
Yeah.
so she needs to be resuscitated first, and her blood investigation should be sent. Blood should be arranged, as you have rightly pointed out, and she has to be taken for surgery right away. So what kind of surgery, whether you want to go for laparoscopy or laparotomy for this patient? She's a case of ruptured ectopic now. Okay.
Yes, she is a case of rupture ectopic.
Yes, yes.
Actually, anesthetist will decide what to give anesthesia, and according to me, in anterior laparoscopy setup, it is available. We can go for laparoscopy. For that, they can go for high epidural or general anesthesia if they are agree. Otherwise, we have to go for open.
No, we are not talking about anesthesia. Definitely, it will be the anesthetist privilege. He will decide what kind of anesthesia. But as a surgeon, whether you would like to go for laparoscopy or laparotomy?
It's better to go for laparoscopy.
Okay. What is the reason behind this?
As we are going through minimal invasive procedure.
Yeah, it's a ruptured ectopic. The whole peritoneum, in the cavity is full of blood. So the older concept was that, you have to go for open laparotomy because you will be able to, do the suction rapidly and catch hold of them. But if you have the expert laparoscopic surgeon, or you yourself is well versed with the laparoscopic procedure, in a moment you can suck away all the blood and you can reach the
everything
point.
is possible.
Yes.
Yeah. We have a very good, we are a magnified view. In a laparoscopy, so
Correct.
to clipping of that the tube or ovary which is bleeding is more easier rather than open it and do everything.
Correct. So in fact, if you are well versed with this laparoscopic procedure, that will be definitely the procedure of choice. Whether you will go for conserving, because she wants childbearing, so whether you want to conserve this tube or you want to go for salpingectomy.
No, if I will say if there is a tubal abortion and just milking of that tube can stop the bleeding after the suction, if I will see if there is no any active hemorrhage or no any dribbling from that tube, if it is a tubal, then I will conserve that tube.
But the very fact that she is landed up into tubal ectopic, doesn't it mean that her tube is damaged, or maybe her tube is not healthy for the future pregnancy? She may land up into recurrence of ectopic pregnancy in subsequent pregnancy.
She may land up, because I had also a same case.
No, but then why we should go for conservative surgery? Because she has one more tube and she has already one issue. Okay, so for a case of ruptured ectopic pregnancy, the message is very, very clear here. For a case of ruptured ectopic pregnancy, we will not go for any conservative surgery. In fact, we should go for the salpingectomy. Okay, so patient needs urgent management as per expertise and availability. Now, what are the learning lessons from this patient? Just early pregnancy, you give the tablet, send her home. Is that the way, or how you should conceal, and what investigations you should do for this patient as a routine?
As a routine, if any female will come to me that I don't want a child and I want an empty pill, then I will suggest her to get done ultrasound, which will diagnose whether it is a intrauterine or extrauterine. If her UPT is positive and if you will not see anything in the endometrial cavity, it straightly indicates that it is not an intrauterine pregnancy. So it's better to go for transvaginal or other, and you have to first diagnose whether it is a
Agreed that you will do ultrasonography. Whether it is a compulsion by law that you should go for ultrasonography, whether it is a compulsion. It is not a compulsion, it is not mandatory, but it is recommended that for your safety as well as patient safety, you should go for ultrasonography. Okay, so the message is very, very clear that we have to go for ultrasonography for the safety of you and your patient. Okay, even though law doesn't make it compulsory. So that is what the message is. Secondly, your counseling has to be very good. That this patient, you have two options for the MTP, that is surgical and medical, and these are the pros and cons of each procedure. You have to make a decision which one you want, and that she has to write. in her own handwriting and sign.
Yeah.
Otherwise, if you pressurize her for going for empty pills, the blame will be on your side. Okay. So that is how the counseling part, it has to be a counseling, complete counseling and informed written consent by the patient and her relative, or maybe husband who is, somebody who is responsible, her caretaker. At the same time, you have to tell her that if she gets, this only spotting of fainting attacks after consuming this, then she has to report to her doctor before, the fainting attacks are because of the stretching of the fallopian tube that gives her, vasovagal attacks. So this is how complete care has to be taken before prescribing any empty pills. So that was just a warming up case for our patient, but definitely I'm sure all of you are well now prepared for managing the other cases. So we have this second case. 36-year-old woman, she conceives after IUI. Her husband is staying in Dubai, he's working there. She stays in village, but because after so much of infertility and elderly gravida, now she conceived with IUI. She comes to you regularly for up to 24 weeks. So seeing that every investigations are normal, now she's lost to follow up, and suddenly at 34 weeks she reports to one PHC with a saying that she's got upper abdominal pain and pedal edema. Her blood pressure is 176 by 116. Growth parameters are apparently normal, but she has proteinuria. And because the BP was high, tablet nifedipine retard was started for this patient. So the patient was advised admission at PHC, saying that she may land up into complications, or maybe she deliver early, but she didn't listen to it. And maybe around a day later, she went to the sub-district hospital because she was referred to the higher center. So where she was, her BP was still high, 170 by 110 with the tablet nifedipine retard. So the doctor added labetalol, and also because she was having alarming symptoms and signs, Maxalpin steroids were given. Cesarean section was done. 1.8 kg live female baby was delivered. Still, her post-op BP with tablet nifedipine and tablet labetalol was remaining between 140 to 180 systolic and 100 to 110 diastolic. So this patient, around 8 to 10 hours after the cesarean section, she, suddenly started becoming restless, breathless, and she started getting cough. Her pulse rate was high. BP was 220 by 118. Her saturation suddenly fell down to 70%. And, chest was full of wheeze and no clear breath sounds. Now, do we have Dr. Kanchan here? I don't think so, but so we can, I think Dr. Shamita or maybe somebody else can take up this question. Dr. Amruta, you can go ahead with this case. So what is your differential diagnosis for this case?
It would be pulmonary edema. Then would be pulmonary embolism. And acute peripartum cardiomyopathy.
Cardiomyopathy, right. So you do have various differential diagnosis, but definitely you have to come to the differential diagnosis. But you will not wait for confirmation of the diagnosis. This is a catastrophic presentation. So how will you manage this case?
First of all, I will call for help.
Yeah, definitely. You can
labet can.
No. First, your patient has become hypoxic. 70% her saturation has gone down to. So first and foremost, you will give her proper. Anybody wants to take up this case discussion? Do we have Dr. Pushkaraj and somebody joined as doctor? Can you please rename, or you can go ahead with the discussion?
Yeah, madam. Dr. Shamita here.
Yeah, Dr. Shamita.
Yeah. So actually, since she's a patient with a chronic hypertension, so one of the reason is pulmonary.
You don't say it is a chronic hypertension. She's having hypertension only during pregnancy, but it is severe.
Yeah, means it is a persistent hypertension for throughout her last trimester of the pregnancy.
It is severe hypertension.
Yeah.
Just diagnosed for the first time.
Yeah.
Okay.
And now she is presented with the pulmonary edema, which looks like that, and differential diagnosis is a
that we have covered. How will you treat this patient? This is an acute emergency.
Yeah. So we'll shift her in a ICU, and we will arrange for a ventilator so that since she is having hypoxia, And
But do your hospital has ICU? Individual
I
small
have.
hospital? Yes.
Yeah, I have one
I think
recovery unit which we have a
Yes,
ventilator.
but then does every small nursing home has a ICU?
No, they don't. So
No.
we will
Suppose
call a
this
family.
happens in a small nursing home. What will you do as primary effective measures?
I will give her a ventilation by whatever
She's
means.
breathing.
Oxygen,
She's breathing well.
Breathing.
Why you want to give her
Go
ventilation?
to
Oxygen.
oxygen
No,
mask.
ventilation by a ambu bag.
Full oxygenation.
Simple oxygenation with mask.
Yes,
Hmm.
definitely. Definitely.
That
Very.
is
So you will make her propped up first. You will give her
Lasix.
oxygenation. She's
Yeah.
got pulmonary edema, so you'll push Lasix.
Lasix, even you
Now
can
we
give
stop
25
here. How much Lasix?
At least
minimum 40 milligram.
40 to 80 milligram. 40 to
80
80
milligram to 100.
Yes,
80 to
40 to 80, because you know, we obstetrician are very scared of giving, you know, Lasix. So maybe 10, 20. No, this is a case where you have to give at least 40 milligram initially, but preferably 80 milligram, because this is, you don't have any time to think. You are suspecting pulmonary edema. And what is pulmonary edema? It is collection of the fluid in the interstitial spaces. And because of this, you can have, you know, the ventilation perfusion mismatch. So unless you remove the fluid from there, you pull into the mainstream, she's not going to respond. So one is Lasix, and secondly, of course, she's got such a severe hypertension, 220 by 118. So injectable labetalol. Okay, injectable labetalol. We will come to the details of it later on. But definitely this patient, because she was so bad that even with this mask oxygen, she, you know, immediately she collapsed. Pulse was not recordable. The oxygen saturation, in fact, came down to 55. So with AMBO-assisted respiration, this patient was shifted to ICU. And just before she reaches the ICU, she developed the cardiac arrest. Now, I can ask who else are the panelists? Can I see some more panelists here? I can see Dr. Pushkaraj. Amruta, can you take up this? How do you manage this cardiac arrest? The basic life-saving measures.
ABC.
Yes. Basically, she's developed cardiac arrest. All of us, as a medico, even on the road, if somebody collapses with cardiac arrest, cardiopulmonary resuscitation. Okay. So you give a thrust on the chest and you give cardiac massage, you give breathing. If she's not breathing, definitely you will intubate her, put her on ventilation. Okay. So basic cardiorespiratory measures, what you have to say, there's a cardiopulmonary resuscitation. And then definitely your anesthetist, your physician, intensivist are there for your help, and they will take care of this patient further, right? So that is how you have to bring her out of this cardiac arrest. And then now you check whether the airway is patent and she's breathing well, circulation, everything. If at all she is not breathing well, then you intubate and put her on mechanical ventilation. That is what we have done already. Now you come for the investigations, do XHS, ECG, echo, and then of course you, which has got wheeze. The bronchospasm, some element of bronchospasm is also there. So you nebulize her. Give her steroids also. Steroids will help you because anti-inflammatory. It will open up the capillaries also, the post-capillary valves also, they are open. And then you try and stabilize this patient. Okay. Now the question comes whether this could have been prevented. Whether this could have been prevented, who can take up this question? Dr. Shamita?
Yeah, man. Actually, the patient was already first time diagnosed with hypertension, and she missed her ANC visits. So actually,
okay.
Patient don't understand the severeness of the disease. So I think since I practice in a rural area, we have a system of ASHA workers, and through them there should be we should track this patient, and at least we try to inform the hello. Yeah, can you hear me?
Yes.
Huh.
We
The
can do.
thing is that the first thing when we detect the patient with these diseases, we have to counsel the patient with a relative the seriousness of it and what are the warning signs, and she has to do the proper follow up and how it can lead to the rarely maternal mortality, and also the severeness we explain. Then we try to trace this patient, and I think the intensive monitoring and doing the investigation can save this patient, and she can whatever she's going to the bad phase of it, so that can be preventable.
Okay.
Mm.
I'm
Also-
sorry. I think the meanwhile the screen share had stopped. So we just continue with this. So what I wanted to ask you is whether this could have been prevented by screening. What Dr. Bella has talked about, early pregnancy screening. Okay.
Yes,
Can anybody comment on this? Yes.
Ma'am, I would like to.
Yes.
During NTNP scan, if uterine artery resistance was seen, then it could have been detected much earlier. Because
Yes.
anyway, the patient was elderly, then IUI patients, such kind of patients generally develop preeclampsia. That's what we have seen.
Yes, perfect.
So, screen could have been started earlier, and the outcome could have been better.
Okay, so that is one point. Your patient was very high risk, 36-year-old infertile patient, and then of course she was she had conceived on ART, IUI. So definitely she was high risk. So you could have done some certain screening procedures, screening tests during early pregnancy. That is one. But the first, you could have given her preventive low dose aspirin and high dose calcium and vitamin D. That is one. But secondly, when she presented to the PHC for the first time with hypertension, that was severe hypertension. So was the drug correct for severe hypertension?
No.
Was the drug correct? Yes, Dr. Pushkaraj, we can hear from you.
Yeah, which drug was given?
Tablet
Just could you go back
nifedipine
two slides?
Nifedipine
Nifedipine retard.
Nifedipine. Maxel should have been given.
When she came for the first time, magnesium sulfate could have been given. She should have been operated right then only.
PHC she presented. No,
Yes,
she presented to the primary health center.
She should
But
have,
what
should have
mistake-
referred earlier.
Yes, what mistake has been done here?
Tablet nifedipine was started.
So that is wrong. Tablet nifedipine retard was started.
Yes.
That is wrong.
First drug of choice should have been levotiol.
It is for non-severe, that is mild hypertension. It is tablet labetalol or tablet nifedipine retard and alpha-dopa, which was an old one. But for severe hypertension, it should be injectable labetalol or capsule nifedipine, 10 mg orange color capsule. Okay. So capsule nifedipine 10 milligram, that is the best possible medication you can give even at PHC. Okay, because injectable labetalol they are not able to give because it is a antihypertensive, can lead to sudden hypotension. Okay, do you understand what I'm trying to say?
Yes.
नारिंगी रंगाची जी capsule असते 10 मिलीग्रामची, any medical professional can give, even the healthcare provider worker also can give, because that is the best medicine. The onset of action is within 5 to 10 minutes. The peak action is within half an hour, and the duration of action is 6 hours. So definitely, if that one single capsule was given at that point of time, her blood pressure could have come down to below 110, and she would have been safe that time. And then she should have been accompanied to the higher center. Right? It's not, PHC, nobody can operate. She has gone to SDH the next day and she was operated there, Dr. Pushkaraj. She has been operated and she has received Maxulf also. But here also they made the mistake that along with tablet nifedipine, they just added tablet labetalol. For a severe hypertension, the basic rule of our body vasculature is that the blood pressure should not exceed 170-110. Otherwise, the patient can have all the complications of hypertension, right from eclampsia, hepatic rupture, acute renal failure, and the pulmonary edema, as we are seeing in this patient, and also the cerebrovascular accidents. Our vasculature is not able to withstand such high blood pressure, and that is why our aim should be to maintain the blood pressure below 160/100. Okay. So 170/110 is definitely a dangerous level of blood pressure that you have to minimize, come down to at least 160, 100. That is a safe range. And then you slowly bring it down to 150, 100 or 150, 90. That is how. So all these things, where things have gone wrong, one is the screening was not done. Secondly, the preventive measures of low dose aspirin and high dose calcium vitamin D was not given. Thirdly, when she was diagnosed initially as severe hypertension, that phase was not treated properly. Otherwise, she would not have landed up into this. And next, when, while taking this patient for cesarean section, you have to restrict the preload. You're giving, 1 or 2 points very fast as a preload. So this also should be try and avoid it. Of course, your methergine, Utrotonics should prefer the concentrated infusion of oxytocin and nowadays carbetocin, and we should try and restrict. Rather, we should avoid methergine. So all these precautions should have been taken. Otherwise, we could have prevented this patient. So this is a totally mismanaged patient, and the reasons being varied, right from her own lack of awareness and her own negligence coming to the doctor regularly. Okay, so that is how what we have learned is we have to be very cautious, and we have to teach our patient basically, so that she is high risk, that you have to write on the paper. And she may land up into all these complications if she doesn't report to the doctor. Whether she follows you or not, that is different, but you write in a language, whatever you have explained her, you write in Marathi or language which she understands. Okay. So that is what the very catastrophic presentation of the case. Now we come to you, Dr. Pushkaraj. We have this young primigravida, 9 months amenorrhea, and she was admitted for labor in a small nursing home nearby. So after maybe few hours, around say 3 p.m. to 11 p.m., that is for almost 8 hours, she was in a small nursing home. She did not progress at all. So they decided to take her up for cesarean section. When the sister tried to catheterize, no urine. And then they realized that last 6 to 8 hours, almost she has not passed urine. Still, urine output was 0. Now, so immediately they referred the patient to a tertiary care center. Bladder again catheterized, no urine output. The patient's blood pressure was 110/70, tachycardia. Uterine contractions were plus. That means there were no relaxation in between. Fetal heart was present, but 100 to 120. Internal examination, she was having only 3 centimeter dilatation. So according to WHO newer definition, she was not even in active phase. Okay, but membranes were absent, and she was having little blood tinge discharge. Okay, blackish discharge. Station was 0. And when the investigations which she had with her, hemoglobin 8 gram%, platelets 1 lakh, PT-INR was 2, and APTT was prolonged. FDP, that is fibrinogen degradation products, were present, and fibrinogen was low, that is 150. I'm sure all of you know that fibrinogen normally should be at least 300 to 400 milligram%. Okay, so what is your diagnosis in toto, and how will you proceed with the management of this case?
This patient has prolonged contractions with no relaxation. That is one thing, and blackish discharge with signs of DIC. So she is case of an abruptio placenta.
It suggests of not DIC, but it suggests abruptio placenta.
Abruptio leading to DIC, abruptio leading to.
Yes. So clinically, it tells you only abruptio. Okay.
Yeah.
Abruptio
Clinically,
placenta with fetal distress, right?
Yes, with fetal distress.
Okay.
Then
and the investigations tells you that she is abruptio placenta, fetal distress, and anuria, acute renal failure. That is what the clinical presentation is. But then on investigations, you get the diagnosis of DIC. Okay.
Yes.
So whether you just let me know whether you will take her for cesarean section right away, or you will arrange the blood and blood products first, wait for that, and then you go for cesarean section.
With the fetal distress, I will simultaneously do both things. I will go for a cesarean section. The blood products should be available, PRBCs, FFP, and platelets as well.
Yeah. So, but then you need to answer the question very clearly, whether you will go for Caesar first or arrange the blood products first.
Arrange the products first.
I would say both the things simultaneously.
Yeah, that I said, but
You have to manage this patient also aggressively because she is in shock.
yes. So blood products will be required.
Yeah.
They'll take a while to come.
Yeah.
In the time,
Once the blood bank assures you that yes, the blood products will be available and they will be delivered, you start working on the operative procedure. Okay.
Yes.
Yeah. So how will you manage this patient now?
Now she is a case of grade 3 abruption. She will require massive blood transfusion. She will require more than 4 in an hour maybe. And for that, after the blood products are given, section is done.
I wouldn't say after the blood products are given. I would say simultaneously.
Simultaneously,
Yes,
both the things are done, and she is delivered. Baby.
By cesarean section. By
Yes, cesarean section.
Yes.
Later on, we will
What
have to.
precautions you will take here during the cesarean section? In addition to blood and blood products, maybe you will give her tranexamic acid.
Yes.
You will give her vitamin K as well.
Yes.
Okay. And while opening, I mean, you have to try and deliver the placenta, baby, everything. And after that, this is the same patient who is in APH. Now she may land up into PPH. So you have to take a precaution that, you know, she should not land up into any kind of hemorrhage for that matter, any kind of, may it be traumatic or tonic. And that's the very reason you give prophylactic uterotonics. You give carbetocin, you give methotrexate, because at present our blood pressure is not very high. Don't take the risk of PPH for this patient, okay?
Yes.
Hypertension you can definitely manage later, but don't take the risk of PPH. Okay. What else?
Management of DIC should be done because the investigation showed deranged, prolonged PT, and the fibrinogen level was also low.
Yes.
So fibrin, FFP, platelets.
Yeah, before going to that, Dr. Supriya, do you want to add something that this patient's, you know, she's got only blood pressure only 110/17, she's got anuria. Does she suggest something?
Actually, she might have land in the PPH. So I will prefer for the uterine artery ligation to reduce the blood loss.
Before operative procedure, I'm talking about. You have to stabilize this patient. You know, why she has landed up into acute renal failure or oliguria or anuria, sorry for that matter. Why she has landed up into anuria?
It is because of the abruption, and DIC causes less renal perfusion, which leads to anuria.
Because of the hypovolemic shock. Because of the hypovolemic shock. Even though, that is what I'm trying to point towards, that even though her blood pressure is 110/70, don't be happy. Her blood pressure may be very high. Because of that, she has landed up into abrupt shock. But now, because she is into hypovolemia, your aim is to correct the hypovolemia. Give her aggressive fluid resuscitation from both
We
the
can add crystalloid. We can add crystalloid and other.
But from both the sides, you give her fast fluids.
IV fluid.
Okay. Yeah. So crystalloids, maybe by the time the blood is getting arranged, you go for colloids also. Okay. And then once the blood is arranged, definitely you start with the operative procedure. See that she doesn't land up into PPH. And then, of course, the massive transfusion protocols, which we will be talking about it in the next case. Okay. So, Dr. Pushkaraj, stay tuned. We will come back to you. So, Dr. Ashwini, we have Dr. Ashwini here.
Yeah.
Yes.
I'm here, ma'am.
Yes, yes. So, Dr. Ashwini, we have this 32-year-old para 1 previous Caesar patient, and she has her first child as 1-year-old male child. Okay. And she comes to you for the first time during 6 months of pregnancy because her husband gets transferred. Okay. So she comes to you as bleeding during pregnancy at home. By the time she reaches the hospital, the bleeding has stopped. Everything is fine. You do her ultrasound, you find that, 26 weeks pregnancy, placenta, previa, with absent retroplacental lake or the sonolucent zone, and the anomaly scan is normal. On further inquiry, she gives you history of early pregnancy hemorrhages in the past also. So this patient at 30 weeks, she is brought to the hospital by the relatives. She was bleeding quite significantly and she collapsed in the hospital. What is your diagnosis that we talk first, and then how will you manage this patient?
Thank you, madam.
Yeah, please go ahead.
My diagnosis would be APH with hemorrhagic shock due to placenta previa. And management would be immediate
Madam,
assessment of the
can I
general
stop you
condition.
here? One more indication here is ultrasonography. Is it only placenta previa or in addition something else?
It can be placenta previa with if it is absent RP lake. It can be accreta or percreta also.
So it is what we call it as morbidly adherent placenta. It can be placenta accreta spectrum, as we call it in a modern nomenclature. So it can be accreta, increta, or percreta, as you rightly said. Okay. So how would you manage this patient now? 30 weeks, bleeding plus collapse in the hospital. How will you manage at present?
Just first I will assess her general condition. Pulse, BP, respiratory rate, and oxygen saturation.
I'm telling you, she's collapsed.
Yeah. But I will assess her pallor first because she is in hemorrhagic shock. Presence of pallor, tachycardia, tachypnea, or hypotension. If it is there, it is a definite hemorrhagic shock. In this, I will inspect her vulva. I will not do PV or PS. And I will determine whether the bleeding has stopped or it is still there. And then if she is in hemorrhagic shock, at least 1 to 1.5 liter of blood she has lost till now. So I will do next will be abdominal examination. If it is a placenta previa, uterus would be soft, non-tender. And then
I want to interrupt you here, Dr. Ashwini, that when the patient is collapsed, will you examine her or you will start her on managing her first?
Yeah, I will start her manage. Just in fast, I will check her.
Okay.
And
but I would still suggest you that you
put ABC, that is airway.
Large bore intracats from both the sides. You will start the IV fluids.
I will do the ABC of the resuscitation. That is, I will start with IV line. Number 16 or 18. I will start RL or normal saline fast. And I will take the blood sample. I will cross match the blood. I will do the CBC blood group and coagulation profile.
Yeah, you will send the
I will
blood
arrange for PCV. And I will give her RLNS, and if here the USG has been done, which is showing the placenta previa. If USG is there, I will see the localization of the placenta.
It is already
and I will arrange
previa and accreta.
On other side, I will arrange for the CS section, and I will take the high risk consent of the patient and relatives.
Okay, so I stop you here. What consent you want to take high risk?
Just maternal morbidity, mortality, fetal outcome, and SOS obstetric hysterectomy if needed.
So I asked Dr. Supriya, what consent you want to take for this patient particularly? Placenta previa, accreta. What consent you want to take? Okay, we pass on to Dr. Pushkaraj, and then Amrita.
Consent for obstetric hysterectomy clearly.
Perfect. That is what we have to, do we have Dr. Neeta also here? Yes, Dr. Neeta? Yes. We want to hear from you. What consent, in addition to the high risk consent as far as the condition is concerned, what consent you want to take for this patient?
Obviously for obstetric hysterectomy, and again for massive blood transfusion.
Definitely. But before the consent, you would like to counsel the relatives, right?
Yes, ma'am. Yes.
Yeah. So what will you counsel them?
That first of all, that placenta is moderately adherent to the uterus. So we will try our best that we will remove the placenta, or else we will keep it like that only, and we will start antibiotics.
I don't think we should say that. We will have the evidence later on. But but what you are saying is what you have to tell. They will say, doctor, she was under your treatment. How she is bleeding? What is your explanation? The patient has come to the doctor at 26 weeks, and today she came at 30 weeks and she's collapsed. The relatives will say, डॉक्टर मागच्याच वेळेला का नाही सांगितलं तुम्ही असं काही होईल, आणि हे कशामुळे झालं? आमची पेशंट तुमच्याकडे ट्रीटमेंटला होती, का ब्लीड होत आहे ती?
As
Yes,
Madam.
Yes, please.
Yeah, madam, since I practice in a periphery, so what we do when we just detect the maternal, placenta previa with PASS syndrome, then we clearly highlight it, put it in the high risk, sit with the patient and ask them to just go ahead with the four to five donor patients, donors, and with their numbers and all. And we always tell them that they have to come with the donors or SOS with the blood ready. And then whenever she comes, she has to report us in an emergency or in our file in a big red letter, so that sister also knows that she is the case of placenta previa. And then we are already ready with our donor list at our hospital.
That is also not sufficient. We are trying to come out with the solution why we'll end up into problems. Okay. So Dr. Dr. Ashwini has very well said that what acute management she requires. Now we come back to you, Dr. Ashwini. I will come to the counseling part of it. Yeah, now you have to counsel the patient that yes, because she has placenta previa, she is bleeding, and nothing can stop her. No medication can stop her. Only she has to get operated at the earliest. Now, why are we worrying about it? Because it is only 30 weeks. So we have to tell them about the prognosis of the baby. That 30 weeks baby, we cannot assure them that it will survive. Okay.
Yeah.
Is it? So, Dr. Amruta, can you please put on your video, all the panelists? I would like to see you, all of you. Dr. Amruta, Dr. Pushkaraj. Dr. Amruta, can you please put on your video? Hello?
My video is on, I guess. Yeah.
Dr. Amruta, is she there? How many panelists we have?
Dr. Pushkaraj is here.
Yeah, Dr. Pushkaraj, Dr. Supriya, and Dr. Neeta, and Dr. Ashwini. Okay, so we have this patient. So naturally, you have to tell them that she is bleeding because she has placenta previa. That you have to tell her. And because unless you remove the placenta or unless you remove the uterus, it will not save her. That is what you have to counsel the relatives. Okay, why you have to counsel? Because you have to take everything in writing. Okay, it's not only explaining the patient and relatives. You have to tell them that she will need obstetric hysterectomy, she will need massive blood transfusion, and any of this treatment or her problem per se can lead to severe acute morbidity, that is near miss or even mortality. And for that they have to sign, otherwise you will not go for any operative procedure without any informed written consent. Okay, that is how you are to. So this patient has placenta previa accreta. Now blood products, everything is ready. And so who should be the part of your team? Who should be the part of your team? Dr. Supriya? कोण घ्यायचंय आपण सोबत? ऑब्स्टेट्रिशियन, अॅनास्थेटिस्ट, पिडियाट्रिशियन, न्यूनेटॉलॉजिस्ट, एवढी तर लोक आपल्याला हवीच आहे. आणखी कोण हवंय?
We may add surgeon.
Yeah. We may add or we must add.
We have to add surgeon.
Whether it is surgeon or you have oncosurgeon, you have.
Better to have an oncosurgeon. Better to have an oncosurgeon.
Okay. Why not neurosurgeon? Why do we want a surgeon basically?
Internal iliac ligation is better done with
before that. See, sometimes this, if it is a placenta percreta, that it is going up to peritoneal aspect. Okay, so that engulfs the bladder also. So sometimes you have to, separate the bladder with cutting the myometrium also. Okay, so for that you have to have a urosurgeon. Sometimes it is so adherent that the ureter also come in between. So when you are doing the obstetric hysterectomy, the ureters come in the infundibulopelvic ligaments. Okay, those clamps. So that's a very reason it is better to have a urosurgeon, if not available, a oncosurgeon, or may it be even a general surgeon for a smaller place. So for our safety, we need this. Who else? We must have the blood bank and blood facilities, which is, with ample blood and blood products. Who else? Two more people we want. And the message why we want this, I will give you. Next is interventional radiologist. Preferably one who can go for uterine artery embolization. Yes, that will reduce the blood loss during the procedure. And one more, the intensivist. Okay. So naturally, if you have all these people, then only you should go for the operative procedure. The message here is, if a small nursing home diagnoses the patient having placenta accreta spectrum, we should label it then and then, but not call for follow-up. Refer the patient to tertiary care center, because that is it is a volcano. It is a volcano. Anytime it can explode. Okay. So that's a very reason, preferably morbidly adherent placenta patient, once you diagnose and label, you should refer it to tertiary care center. Now we come to certain questions for you, Dr. Supriya. And then we can go for Dr. Ashwini also. Was it preventable?
Just now when she appeared to our hospital, this is not preventable.
No,
but
no. Dr. Supriya, the patient had come to us at 26 weeks also, no?
Okay, so at the 26 weeks, you can tell her first
Definitely.
hospitalization at least for 48 to 72 hours, or till
Here
the point she
have,
should stop her bleeding.
No, here we have a difference of opinion. If you have a patient of placenta previa who bleeds intermittently, we should not allow them for the domiciliary management. Domestic basis, you should not manage them. We have to keep their blood reserved all the time, and preferably we should hospitalize them. Okay?
Yes, we have to hospitalize her first.
Yes.
Then she stops her bleeding. And at the same time, we have to arrange for all this blood and everything, and we have to explain everything.
Okay.
If she stops her bleeding at that time, then we should go for a corticosteroid for the lung maturity of baby, because she.
Okay. Before that, I ask you for certain questions. We asked Dr. Shamita. Dr. Shamita.
Yes, ma'am.
Yes. So when you diagnose placenta previa, should we put a stitch to prevent all these problems?
No, ma'am. There is no use of unnecessary
Prophylactic
going to.
hospital.
No,
Yes.
no, not at all. It
Okay.
is
So
it should
perfect. Should we start her on some tocolytics? Duodenal वगैरे करायचं का सुरू?
Actually, evidence based मध्ये त्याचा काही रोल नाहीये, but practically at least tablet Duodenal 10 milligram BD we can start actually.
But then this patient did not have any contractions. Still she had bleeding, no? Because for placenta previa will bleed all of a sudden without any reason.
Yeah, it's a painless bleeding without any contraction.
Yeah, that is why there is no role of tocolysis. Evidence doesn't support prophylactic cause tightening, doesn't support tocolytics, and also it of course definitely advises you management at tertiary care center, hospitalization with keeping the blood and blood ready all the time. And of course the patient, the patient when she came to you for the first time at 26 weeks, what precautions you should have advised that time, that was missing. Okay, so can somebody tell me what the precautions we advise for our patient?
Actually,
low lying, no, I would say bed rest, but yes, definitely not to have intercourse, not to go for internal examination.
Exercise.
Yeah,
No
not to go
prolonged
for any
standing.
strenuous work. वजन
No
उचलायचं किंवा
prolonged,
प्रवास.
yes.
Correct.
No prolonged standing or no traveling should be
actually,
avoided.
Madam, nowadays we call it as a pelvic rest. and she should avoid jumping movement so that any pressure at the cervix to be avoided. Otherwise, she can move around. That's what I feel.
That is what I'm trying to tell. There is absolutely no place for bed rest. In fact, that will worsen the situation. Thromboembolism, all those problems will, happen. So what RCOG recommends that if you find, low-lying placenta, the placenta within 2 centimeters of the internal os, you label it as low-lying placenta then only. And when it overlies the internal os, crossing from one end to other end, you label it as placenta previa. And at anomaly scan, you also look for the retroplacental sonolucent zone or the venous lake. And if that is absent, you label it as placenta accreta or morbidly adherent placenta, and then such patient has to be managed or referred to the tertiary care center. Small individual nursing home should not manage the placenta accreta spectrum patients, even if you have blood bank facilities, even if you have surgeons in-house. Please do not take a risk, because in spite of doing everything, these patients, they bleed. You may have to even go for internal ligations, and in spite of all this, when you are going for massive transfusion protocol, these patients land up into dilution, DIC, what is called as dilution coagulopathy. And for this, I think we will have Dr. Pushkaraj's opinion on this. How do you initiate the massive transfusion protocol? Dr. Pushkaraj.
Yeah, massive transfusion protocol is given. There are a few indications for it. Replacement of the entire blood volume within 24 hours, or transfusion of more than 10 units of packed blood cells, or a transfusion of more than 4 units in an hour, transfusion of more than 20 units in 24 hours. So once the massive blood transfusion protocol is initiated by the physician, we have to give packed blood cells, FFP or cryoprecipitate, and platelets in a ratio 1:1:1.
Little difference of opinion here.
I
will not recommend platelets to be given. For platelets, you have specific recommendations. Unless the platelet count goes below 10,000, you will not give any platelet concentrate. Okay. Rest everything is okay. So what is the proportion of packed cell and FFP?
1:1.
1:1.
1:1. Perfect. That is what you have to say it out so that you are confident. Okay. 1:1. One this and one this. Okay. So that is about the massive transfusion protocol. So you may need multiple blood and blood products. May it be whole blood, the packed cell volume, or the fresh frozen plasma, and in some condition even the cryoprecipitate. Of course, you have to maintain this ratio, and you have to time to time you have to go for the coagulation profile. At the same time, you have to see that your patient is not going into dilution coagulopathy also. Okay. So that is how you have to keep a watch. Now, for this patient, just for the surgery, suppose you are a managing doctor and you want to take up this patient. Suppose this patient is being managed. Now we are talking about the prevention. You are managing obstetrician. This patient is under your care. The relatives have signed everything. You have the blood and blood products ready. The patient, suppose you want to take her for elective cesarean section. When will you go for cesarean section? At what gestational age? She is not bleeding, but you for this placenta, it's a central placenta previa with accreta. So what is the right time to go for cesarean section?
Past 34 weeks.
Yes, perfect. Before that, how will you prepare the baby?
Antenatal steroids.
Steroids, okay. And
magnesium
sulfate. Yes, magnesium sulfate for neuroprotection. I hope, I take it for granted that all of you know the dosage.
Yes, ma'am.
Yes, can you please say it once?
Generally, Shamita here, we give 4 grams of magnesium sulfate.
Okay, steroids first. How much steroids? Which steroid?
Generally, we have available here Dexa, so we give 12 milligram of Dexa and repeat after 12 hours. And then Maxel 20 minutes loading dose and followed by 1 gram.
What is the loading dose?
4 gram in 20 minutes in IV.
So that is diluted. Okay. 4 gram, that is 8 ml, you dilute in 12 ml of normal saline. So that becomes 20 ml. So you give it over 5 to 10 minutes. Nowadays it is not so, not so slowly. Previously it was recommended 20 ml in 20 minutes. Okay, so you are giving this loading dose and then you maintain the infusion as 1 gram per hour.
1 gram per hour for
Okay.
24
For
hours.
24 hours. That is okay. So for steroids, may it be betamethasone or dexamethasone, 24 milligram over 24 hours. Okay. That is what the dosage recommend. Now you have prepared this patient and the baby also well. So before the surgery, what precautions you want to take? What you want to ensure that whether you want to see that electively, when it should be operated electively, if she's not bleeding, it should be operated electively, because the senior obstetrician, senior anesthetist, senior neonatologist, and even the blood bank, everything is all set ready for your patient. Okay, late hours of night you will have problems. Okay.
If MRI is available, an MRI to see if how much the placenta, is it increta, percreta?
Does it make any difference in the management?
The planning, if at all, the surgeon will be well prepared for it. In a tertiary care, this is possible, but in our rural setup, maybe a highly skilled USG can also.
No, but what difference it makes? Suppose you have this patient and you have planned for obstetric hysterectomy. What difference it makes?
The difference it makes, man, if it is reaching towards the bladder, then we have to be prepared with the urologist.
Yes. But that as a routine, we are advising you to have your team well equipped with all this, infrastructure and the team also. Okay. But yes, why I'm asking you this question, Dr. Pushkarash, it is said that, if you have an expert sonologist with a good resolution sonography, diagnosis of placenta accreta spectrum doesn't require, the results are equally good as far as the ultrasonography and MRI are concerned. So they are comparable. Okay. Only if you have a very obese patient and when you think that the placenta is posterior, then only MRI is of help. Definitely, MRI is of help when I'm asking you the question why? Because suppose you have a nullipara, she's a primary, suppose. Our patient is a second gravida. But suppose she's a primary and you have a thought that maybe you can conserve the uterus. Okay. Because this is only 30 weeks and maybe you may lose the baby also. So if you want to conserve the uterus, the only indication here is if you have only a patchy adherence of the placenta. It is not a generalized adherence. So if you have a patchy adherence of the placenta, that is what is called as triple P procedure. Are you aware of this procedure? Yes, any of these panelists, are you aware of this procedure?
No, man, I'm not.
So I will tell you just in short that if you have this placenta accreta spectrum and she is bleeding and collapse, you have basically go for obstetric hysterectomy elective. That means before the surgery, you have to take an informed written consent for obstetric hysterectomy. Okay. But suppose you have a patient for whom you are suspecting patchy adherence and she's a nullipara and you want to try and conserve the uterus. Okay, that's the only indication where you have to go for conservative surgery, and that procedure is called as triple P procedure. One is what is called as the mapping of the placenta. So placental mapping, that is one. Okay, placental mapping. That means before the surgery, you map the placenta, what is the extent and where are the patchy adherence. Then what is called as the stepwise selective devascularization of the pelvic vessel. So pelvic devascularization, that is a second P. Mapping of the placenta, mapping of the placenta, selective devascularization of the pelvic vessels, and third is patchy resection of the myometrium. So this is a procedure what is called as triple P procedure. This is not to be attempted at individual nursing homes, even if you are equipped with all the facilities, and even if you have a multidisciplinary team. So what are the special precautions, Dr. Neeta, during the procedure? What incision you take on abdomen? What incision you take on uterus? I think that's only few questions, I think. And we will wind up. If you feel so, we can continue with the last quiz. Okay.
Mostly on abdomen, we prefer phalansteal or obviously transverse incision, and on uterus.
For this patient, you want to go for
No,
transverse incision?
Vertical incision.
Vertical.
Yeah. Okay.
And on uterus, if we can take obviously mostly incision should be taken on mostly vertical incision is taken as to provide baby should be delivered fast for fast delivery as
Not for that.
No,
you have to see that you are not cutting the placenta.
Yes, we should not cut the placenta, so vertical incision is taken on the uterus.
And sometimes, see, basically the abdominal incision is not very important. If you are well versed with the phalansteal incision, the extended phalansteal incision also can be taken, but the uterine incision has to be a classical incision and it should just stop short of the placenta. It should not cut the placenta. Okay. Some people recommend what is called as transfundal incision. You just cut along the curve of the fundus as it is. You're going to, remove this uterus. Okay.
Yes.
That is what. Okay. And then definitely after you remove the baby, definitely no attempt to separate the placenta. If it is a diagnosed case of morbidly adherent placenta, no attempt to separate. If it is coming out spontaneously, maybe the diagnosis is wrong sometimes, that is well and good, but you will not make any attempt to pull the placenta. That will lead to torrential bleeding. So wait for a certain period. If she is not bleeding and not separating the placenta, go ahead with the obstetric hysterectomy as you have decided. Okay, definitely sparing the bladder, taking care of the ureters, and then of course, as I have said, it is stepwise pelvic devascularization to avoid all types of bleeding will definitely help you. We have already talked about the interventional radiologist, the help, how you can check you can go for uterine artery embolization. This is all about the massive transfusion protocols. I will not go. We have already discussed. We will skip all these cases. I do have very interesting cases, but only last case because this is very important and very practical. You have this grand multipara, admitted to emergency at 11 p.m. as a case of obstructed labor. She's got tachycardia, pulse BP, blood pressure is normal. She's exhausted and there is a thick meconium stent like her. So you go for cesarean section. Baby, 4 kg distressed baby is delivered. There was a slight extension because it's a large baby. It was repaired well. There was no bleeding. So after shifting to post-operative ward, hardly after 1 hour or so, the patient's blood pressure dropped down to 80 millimeter of mercury. The pulse was steady. Respiration was disturbed and it was, the look was drowsy. There was a vomiting tendency. Okay. When you examine the patient, no pallor. And there is no bleeding also. Uterus is well contracted. What is your diagnosis and what bedside test can point towards this? Dr. Pushkaraj, I think you can quickly discuss this.
Yeah. Firstly, in the history, we have a large baby and a prolonged section. So large baby more than 4 kg. Second, there is no bleeding with shock. So non-hemorrhagic primary obstetric shock, we can have a DD of embolism or ketoacidosis.
And
another
can be
one is
also hypoglycemia. Can be. Okay.
Yeah.
Okay. So how will you manage this patient? How will you manage this patient? Yes.
Yeah. We have to give a fluids. First of all, do the blood test.
No, but you have to take care of her. She is collapsed. So definitely you have to give her aggressive fluid. BP is very low, so you have to give vasopressors.
Yeah, hydration, electrolytes, and insulin.
Okay, so you do her bedside test. Her hemoglobin is 10.8. Her sugar is very high, around 550, 600. Okay, urine ketones 2 plus.
Yeah.
What is your diagnosis now?
Diabetic ketoacidosis.
Okay, so for her, we gave her 15 units of insulin as a bolus, and then insulin infusion was maintained. So within an hour or so, this of course we did it with the help of physician. Her sugar came down to 321, and the patient made a good recovery. Okay, she has. You have seen what catastrophic picture she had, but insulin was a sanjeevani for her. So this patient, she had malaise, hypertension, hyperglycemia, dehydration, tachycardia, tachypnea, all these, symptoms and signs as well. When we did her investigation, the pH was less than 7 almost. And that is what we stressed on the fluid replacement. So over 24 hours, how fast you have to correct, she was really, really very, because she was a case of obstructed labor, if you remember the history. And then, of course, I will take it in short, whether it could have been prevented. What is your answer for this?
Yes, definitely. With good antenatal exam care, OGCT is the first time. Even before that, when we do this ANC profile, their high sugars, that time we can diagnose such a case of a diabetes patient with pregnancy, or if it is a GDM, OGCT can help us. After that, with polyhydramnias increase, as Dr. Bela Bhatt had shown, USG monitoring, that can help us diagnose such a case.
Yes.
And in such a neglected case, when she comes directly in labor, a big size baby not delivering so easily, 4 kg baby, even if it is delivered, we should do a sugar level because it is a 4 kg baby, a large baby.
Yes, yes. So first and foremost, what is called as universal screening for diabetes or hyperglycemia in pregnancy. Universal screening. So you go for either, see, if she is giving you history of diabetes, go for the sugar levels and HbA1c at the first visit. If she doesn't have any history of diabetes, it is a compulsion, I would say, that every woman should be screened for gestational diabetes during every pregnancy. Not only one first pregnancy, but every pregnancy. It is such a simple test that you have to do. And of course, as you follow the pregnancy, the first test has to be done right at the first point of contact, that is first antenatal visit. And then if that is also negative, then it has to be repeated between 24 and 28 weeks of pregnancy. And definitely, when you are telling your patients, admission test, NST, this, that, why not to go for the basic CBC and glucose, on the day of admission? So the message here is every obstetric unit and every person of the obstetric team should be well trained and skilled to manage the maternal collapse. Because as I have shown you the initial picture, normal labor can turn into a catastrophe anytime. And that is why you have to be well equipped and well versed with the management of the obstetric shock or maternal collapse. The team should manage effectively then and there only. You have heard Dr. Rajendra talking about, you can't refer the serious patient or patient in a serious condition. You have to at least stabilize the patient. So shifting the patient in a serious condition is a crime. And that is what we have to keep it in mind. Once again, I thank all the panelists for your excellent inputs. And I thank all the president and secretaries of all the societies for inviting us for this session. And I hope I have done, I have made some change in your concepts and, trying to help the managing patients in rural setup.
I would like to comment, Sneha madam, something that it was a great learning for us. Though we are practicing so much, but it was a refreshing and learning for us. So elaborate and so precise you have talked. So it is really going to help us. Thank you very much, madam.
Thank you so much.
Thank you so much, man. Thank you so much. It was just a superb session. Really, it's a great thing, madam. Thank you.
Thank you so much, Dr. Rajendra and Dr. Sanjay, and thank you everybody for that.
Thank you, madam.
Fact,
Thank you.
Thank you. So, in fact, what I want to share from my side is माझं जे पॅनल मॉडरेट करायची पद्धत आहे, मी मराठीत बोलते आता. पॅनल मॉडरेट करायची जी पद्धत आहे ना, इट्स नॉट की तुम्ही तुमचा अप्पर हँड दाखवा आणि यू शो युअर नॉलेज. Why I'm happy? Because all the panelists have studied so much and they have questioned me personally, communicated with me, and they have tried to solve their queries by discussing with me. So I'm happy and satisfied that at least they refreshen their knowledge, and they are trying to manage their cases so well. So I'm happy that at least some change has been made, and really thankful to all the 3 societies. Thank you so much.
Thank you,
What
madam.
do you
Thank you, ma'am. Thank you.
Thank you, ma'am.
Thank you. Thank you.
Thank you. Monica, I would just say once again that I thank the AMOGS president and secretary for having such wonderful societies with us, and definitely I'm personally very happy because getting connected with the smaller societies, I really feel connected with you, and thank you so much for everything, I would say. Thank you so much.
Thank you, madam.
Thank you, and hoping to be with you for some more sessions. And definitely, all of you know that I'm going for vice presidential elections. For me, elections is not the only issue. For me, I'm satisfied as a practitioner, successful practitioner, and I'm happy that I'm holding so many posts also. But definitely, if you feel I deserve, please do vote and do help me in my endeavor of going ahead in Foxy so that I can represent all of you. Thank you so much.
Thank you, madam. Definitely.
Thank you, madam. Definitely. 100%. Thank you.
Thank you so much. Bye-bye. Monica
Thank you.
and
Thank you.
Madan, thank you so much.
Thanks. Will you?
Thank you so much, Saiti. Yes. Yes, Monica.
Yes, ma'am.
Thank you, ma'am. Thank you. Monica.
बोला ना. I would like to thank Sahiti Priya from Shield Pharma for giving the technical help to all of us and all the esteemed faculty members who have joined us. Dr. Respected Asha Dalal Madam, Kalyan Sir, our speakers for today, Dr. Bela Ma'am and Dr. Rajendra Tiwari Sir, our chairpersons, and our panelists have done an excellent job. They have brought out the real academics, and a very fruitful discussion followed the panel discussion. Thank you, everyone, and good
Thank
night.
you so much. Thank you, Monica, and thank you, Madan. Thank you, Saiti Priya.
Thank you, ma'am.
Bye-bye. Thanks, Dr. Supriya, Amrita, Dr. Neha, Ashwini,